Three, two, one. We are live now, sir. We can start.
Good evening, everybody. Myself, Dr. Vishal Dave, Medical Advisor, Intas Pharmaceuticals. On behalf of Intas Pharmaceuticals, I welcome you all for the Synergy 21 webinar on the topic Understanding Ovarian Masses. Before starting the webinar, we will have a prayer.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
It is my privilege to introduce Dr. Monica Singh. Dr. Monica Singh is convener of the Synergy Club series. She is president-elect of Bhopal OBGY Society. She is founder-president of ISOVAB chapter of Bhopal. She is national executive member of ISAN. She is joint secretary cum joint treasurer of MPIAG. She is coordinator of Foxy Infinity Committee. And she was also convener of Perfection series and Symbiosis series. Over to Dr. Monica Singh.
Thank you, Dr. Vishal. Dr. Vishal, before I start formally, I would like you to make a call to Dr. Usha Sharma, madam, past president ISOPAP. If you can please get the number from the group. Madam is having some problem in joining.
Yes, ma'am.
Please. Until then, I will proceed. It is an extreme pleasure and honor for me to begin on the Synergy episode 21. This webinar is now close to 2 years. We have done multiple programs and we take pride in giving ICOG points to our viewers. This particular program has been awarded 3 ICOG points, and for this we are very grateful to Foxy Societies Aligarh, Gorakhpur and Meerut. From the Gorakhpur OBGY Society, we also have along with us the Onco Integrated Research Foundation, because this topic of ovarian masses also carries a definite link to malignancy. So we thought it is a good point, and President Gorakhpur, madam, was kind enough to give us permission to collaborate with Onco Integrated Research Foundation of Gorakhpur. Today, we will study about ovarian masses, and we have amongst us luminaries, our chief guest, Padma Shri Dr. Usha Sharma, madam, and our chief guest, Dr. Meera Agnihotri, ma'am. Dr. Usha Sharma, ma'am, will not be able to join because she's traveling, but it is a great honor for me to be in the midst of, in the presence of Meera, madam. Next, we have a guest of honor, Dr. Usha Sharma, ma'am, from Patna, Dr. Bharti Maheshwari, madam, from Meerut, and Dr. Nilesh Dalal from MGM Indore. Dr. Nilesh Dalal is also on an important government assignment and has sent his blessings to us. Our special guest for today evening is Dr. Rachna Dubey from Bhopal, a very, very dear senior and friend. My co-convener for the evening is Dr. Randhir Singh, Managing Committee member of ISAR. And my program coordinators are these 3 beautiful ladies, Dr. Purva Bhatkur, Dr. Nandini Singh Bhati, and Dr. Ankita Upadhyay. So I would now just walk you through the program and how we're going to conduct it. Dr. Vishal? Yeah. So as you can see, we have been planning this program for close to 3 weeks now. And we do just one focused webinar per month so as not to dilute the importance and gravity of the whole program. This is a pure academic session, and we want to the viewers, the clinicians, practitioners, as well as students to get full benefit. It's as if you are going through a chapter of ovarian masses. So we will start with IOTA methodology, and who can be better than Dr. Sonal Panchal to teach us about IOTA methodology and how we can inculcate this in our practice. Next, we will have a lecture on management of ovarian masses and how can we read between the lines by Dr. Jyoti Jaiswal, Professor, Raipur Medical College, and HOD also. Next, we have a very interactive panel discussion moderated by Dr. Girja Wagh from Pune with a galaxy of panelists drawn from all over India. So without wasting time, I would like to welcome and pay my respect to Dr. Meera Agnihotri, ma'am, Chief Patron UPCOG, who has joined us as chief guest. Madam, namaskar. And greetings from Bhopal, greetings from Synergy Club. We are so grateful for your kind and benevolent presence in the program because we associate you with not only leadership, a lot of dignity, a very gracious presence, but also loads of academics. Madam has been professor and head of OBGY at the prestigious GSVM Medical College, Kanpur, and chairman of the Ethics and Research of the State Medical College. She's also been advisor of Women Health Cell Ministry of Health, Government of India, and is the president of WWW Foundation. She represented India as chairperson AIDS Committee in the 9th International FIGO Conference at Canada. She organized the International Women Health and Empowerment Conference, first ever inaugurated by the President of India and the Union Health Ministry.
Monica, it's all right.
We can
Monica, please. Thank you very much
Madam,
for
just
loving words.
two words.
I'm a part of this family. So everybody knows everything about us. I always feel that I'm a part of your extended family.
Thank you.
So, first of all, congratulations for making this wonderful academic session, which is of great value. ओवेरियन मासेस के लिए बचपन में जब हम लोग पढ़ते थे तो कहा जाता था न तुम समझ सके न हम समझ सके. So it is like this. Anyhow, I am very happy that there is an integration of Aligarh, Gorakhpur and Meerut Society. I believe Usha ji is very shortly joining us. Even if she doesn't join, my heartfelt regards to her as a chief guest. The guest of Halal, special guest, Dr. Rachna Dubey, and these Aligarh, Gorakhpur and Meerut President and Secretary, I welcome them here. I am really very happy to learn about this Onco Integrated Research Foundation because I have not joined it earlier, but I know that they must be working very hard. How long it is to be their existence? Onco Integrated Research Foundation, Monica?
Madam, I don't have the exact idea. Madam, I don't have the exact idea, but it has been formed in collaboration with the surgeons and gynecologists. So the president is Dr. A.K.
Okay.
Chaturvedi, and secretary is the president of Gorakhpur, Dr. Dipti Chaturvedi, madam.
Okay. Anyhow, but whatever it is, the thought behind this wonderful thing is that the president, Dr. A.K. Chaturvedi and Deepti Chaturvedi, I congratulate them to just break out the bifurcation of this particular branch because you cannot separate it from the other subject, but it really needs special attention, especially in the area of today. It is the need of hour and demand of the time because the patients are increasing day in, day out. I'm very happy to learn about the topics which you have selected. IOTR methodology number 1, which is being taken none other by Dr. Sonal Panchal. I congratulate her. Second speaker is Dr. Jyoti Jaiswal, Management of the Ovarian Masses, how to read in between the lines. In between the lines are always very ambiguous and it is very difficult to calculate out in between the lines. And the panel discussion, none other than Girja Wagh. I congratulate all the panelists and I extend my heartfelt thanks to you and all the collaborating societies, especially Aligarh, Gorakhpur and Meerut, for conducting such a wonderful subject to be conveyed up to the last person. Because you all know that in last 1 decade, a revolutionary change has occurred in the management strategies and we have stopped telling that these masses, even if they are malignant, we can overcome them. So thank you very much for calling me. I can't see Randhir here. What is he doing? Where is he gone? He's not here.
Madam, there is a concurrent meeting.
Convey my love and blessings
There is
to
a
him
CMH.
also. Once again, I congratulate you Bharti has joined, I believe.
Namaste,
Jyoti
namaste,
has
ma'am.
joined. Vishal has
Namaste,
joined.
Meera ma'am. Namaste.
Namaste. So, love you. I'm still there on
Namaskar.
work, and I will be here for another 15-20 minutes, and I'll be listening it. I love to hear, but because of very many things, I may not be able to be there up to the end. So thank you very much once again for all the dignitaries and the speakers, Sonal, Jyoti, and Girja. I think they have joined. Usha ji has not come.
Madam,
No,
Dr.
madam,
She is
she
busy.
is traveling, so she couldn't join. Yeah.
Ma'am, Dr. Usha
Okay,
Sharma
okay.
is traveling, but Dr. Usha
So,
Sharma is
please
joining.
continue with the program. Don't waste time in introducing the persons like us, because we are your family and you know in and out of ourselves. Everybody knows everything about us. So thank you very much, Monica, for making me a part of this program. And I will always be there whenever you call me, because I think I cannot refuse this regiment at least, because I have to be there many times. Thank you very much.
Thank you. Thank you so much, ma'am. We are really grateful for your blessings.
Thank
And
you,
your-
Meera madam, for your blessings.
And your hand is always blessing us at all times, ma'am. So, Madam is there with us for another couple of minutes, and we proceed with our guest of honor introduction now. Dr. Purva, could you help Dr. Usha Sharma to join, ISOPA President?
Ma'am, madam is not receiving call at present.
Right. So I will introduce first Bharti Madam. So, Dr. Vishal, yes. I take great pleasure and it's an honor to introduce my very, very dear senior and mentor, Dr. Professor Bharti Maheshwari. Madam is not only our guest of honor, she is also representing Merit OBGY Society by her gracious presence. We always know Madam as a very keen academician. And the way she conducts her academic sessions, she keeps you glued to the screen because you really want to attend all her lectures or attend all her panels, which are full of clinical take-home points. Madam has been professor in HOD at Muzaffarnagar Medical College with lot of accolades to her credit. She has headed the FOXY MTP committee as chairperson, ICOG. She's been secretary of UPCOG, and of course, she's the president of Merit OBGY Society. Ma'am, the stage is all yours, and we would like to have your blessings before we start the program.
Thank you, Dr. Monica. And in continuation, I am a president of Merit ISOPAB and Merit Menopause Society also. I think the CV is old. But thank you very much for inviting me. Harmony jalna hai. Acha, thank you very much for inviting me. As uh, Dr. Meera Jyoti Madam already said that we are family and you have organized such a wonderful webinar. So I just want to give message to all audiences, those who are just attached with this webinar, that ovarian mass, of course, it is a thing that of course needed learning, because daily day-to-day update, not only by the imaging, lots of advancement in imaging, as well as lots of biochemical tests, blood tests, as patient's history, age, that give lots of clues, so that timely management of the patients is possible and optimal management is possible. So without doing any delay, I would love to hear this webinar, and we will get some, and Dr. Sonal Pachal, Dr. Jyoti Kaiswal, as well as Dr. Gijawag, they both are all also learned person. So I wish all the success of this academic program, and congratulations, Dr. Monica, Dr. Ranveer, and whole organizing team for organizing such a beautiful webinar. And I wish that you continue the same academic series. So thank you very much and best wishes.
Thank you, Bharti ma'am. And we would love if you could be there in the program when we start. And we would like to now pay our respect. Dr. Nilesh Dalal, as I mentioned, is in an important government assignment, but he has sent his best wishes for the program. We are honored by his presence as guest of honor from wherever he is working right now. But we have with us a special guest for the evening, who is none other than Dr. Rachna Dubey.
Hi,
And
hi, Monica.
Dr. Rachna Dubey is such a star in Bhopal, so helpful, so approachable, and I think she's a total reflection of Meera Madam. So whenever we see Rachna ma'am, we remember Meera ma'am, and whenever we see Meera ma'am, we remember Kalpana Didi, Rachna ma'am, everyone. So Madam
Hi,
has
Dr. Rachna. Yeah,
Hi,
hi, Dr.
very
Rachna Bharti here. Nice to
hi.
meet you. Yeah.
so
Same
Madam.
here.
Madam is heading the, the state nodal for preventive gynec, onco and infertility. She's the state in charge state of art center for preventive gynae, onco and infertility at the government K&K hospital in Bhopal, which has seen a radical change for the for excellence under her leadership. We have recently, attended lots of drives like tree plantation drive under her leadership. She takes great interest in all the government programs and makes it a point that there is healthy collaboration between the public and the private sector for the benefit of our patients. She's been awarded so many awards by the government of Madhya Pradesh. She's attended, just in the last couple of years, an important executive program at Harvard School of Public Health where she was awarded. She's written books and her passion is PCOS. We recently had a very nice conference on PCO by the PCO Society of India under the leadership of Dr. Durusha and Dr. Rachna Dubey in Bhopal. We are proud to host it. So, Rachna ma'am, the stage is all yours, and we are so
Thank you
thankful
so
you
much
could.
for the wonderful, wonderful words, Monica. Respected Dr. Meera Agnihotri Madam, Usha Sharma Madam, Dr. Nilesh Dalal is not over here, Dr. Bharti Maheshwari, and all the esteemed colleagues with me here. It's truly, truly a pleasure and an honor to be with you all in this wonderful webinar and be a part of such an enriching academic session. In fact, I would like to extend my very sincere gratitude to Monica. She is so, so full of praise, and we are mutual admirers. And her dedicated team for organizing these wonderful synergy episodes. They are so, so informative, and it has gained so much of popularity in the past so many years. Not so many years, it's just been 6, 7 months, I believe. And people just want to listen, and hundreds and hundreds of doctors across the country are listening to these synergy webinars, and especially this episode is very close to my heart, being the head of the preventive oncology and fertility and gynecology, the topic ovarian masses, because it holds a lot of importance. Doctors usually in the government setup, I have seen that they are only limited to doing LSCS, normal deliveries, and basic obstetrics. But these topics, in fact, I wanted all my doctors in KNK and across the state to attend such webinar, because gynecological issues are discussed but not an important integral part of the maternal health. So I'm sure this is going to be really, really helpful to all the doctors across the state and across the country. Thank you very much, Monica. You are a wonderful host, and I would love to listen till the end. Let's see how much I'm able to. Thank you. Thank you so much.
Thank you. Thank you so much, Rachna ma'am. I know this is your OPD time and you're so busy, but definitely we loved your presence here and we would really feel happy if you could stay for some time more.
Or I would myself love to.
Thank you. Thank you so
Thank
much, ma'am.
you so much.
And
Thank
I
you.
hope under your leadership, our state is able to combat, all sorts of malignancies in a big way through preventive gynae. Because
Yes,
we
yes.
all know that
Having a good,
prevention is,
strong partnership of the private people also with us. So I'm sure it's going to go a long way.
yes, and prevention is always better than cure. This program would not have got its, stature as well as the ICOG points if we didn't have our Foxy societies. The Foxy societies are our backbone through which our programs work. So we, in alphabetical order, we introduce our societies and the dignitaries. From Aligarh OBGY Society, we have President Dr. Minakshi Sood Madam and Secretary Dr. Zehra Mohsin Madam. So I would love to introduce both the dignitaries to you. Dr. Minakshi Sood is president of Aligarh OBGY Society. She is senior consultant at Sood Hospital, Aligarh, a life member of IMA, founder of Sood Hospital, and is an alumnus of the prestigious KGMC Lucknow. Madam has held the post of President Aligarh Obs Gynae Society from January 24 and was also the founder secretary of Aligarh Menopause Society, which she is still continuing till date. She is master trainer HPV vaccination with special interest in adolescent health and high-risk obstetrics. Welcome, Madam. We would like to have blessings from you, Madam.
It's my profound pleasure and privilege to be in this prestigious webinar, Dr. Monica, and you've been very kind in communication and very, kept us updated. Ovarian masses actually is such a topic which any gynecologist would love to, listen to such esteemed speaker. So thank you so much for including Aligarh Society for this webinar. Thank you.
Thank you. Thank you, Meenakshi ma'am, for the short and sweet words. And now our guest of honor is also there. So before introducing Zehra madam, Vishal, can we have the CV of our guest of honor, Dr. Usha Sharma from Patna? Good evening, Dr. Usha Sharma ma'am. I know you are going to go shortly for a meeting. So we will, ma'am, try to free you within 5-10 minutes. It is a great honor and pleasure to welcome amongst us past president of ISOPAP. ISOPAP, we all know, is the Indian Society of Perinatology and Reproductive Biology. And madam, we are proudly, proud of the fact that Bhopal chapter of ISOPAP, we started in October 2024, and I'm the founder president. Madam is consultant OBGY at Patna SK Memorial Hospital and AK Memorial Nursing Home, and honorary consultant at Red Cross Polyclinic, Patna. She has delivered orations, keynotes, and scientific deliberations all over India in various societies. She is a keen academician, has contributed chapters in Foxy Books, and is the former East Zone Fellow Representative of the Royal College of Obstetricians and Gynecologists. Thank you, Usha ma'am, for blessing us with your presence. And madam, please, we would like to have a few words from you.
First of all, I thank you for inviting me for such a knowledge-enriching webinar on ovarian masses, which is difficult for any gynecologist to treat. Now I start with, it gives me immense pleasure to attend today's webinar on understanding ovarian masses, organized by Synergy Academic Club. Sharing this digital platform with Padam Shri Dr. Usha Sharma and Dr. Meera Agnihotri is always a matter of pride and joy for me. I also know Dr. Bharti Maheshwari personally. Her good teaching, I appreciate her good work as well. Regarding the theme, ovarian masses are found in 6.9 to 8.5% of general population from childhood to menopause. Differentiating the malignant from benign ovarian masses definitely decides the management options. The International Ovarian Tumor Analysis Group, IOTA, which you are going to discuss today, was founded in 1999 in the European country. Standardized the pre-operative assessment of ovarian masses, developing terminology in gynecological sonography. Simple rules in 2008, the classification states benign if only B features apply. There are 5 features in each. Malignant if only M features apply, and inconclusive if both B and M features apply or neither. Now, mathematical models like ADNEX is being applied today with a lot of, they take mathematical models like ADNEX to predict malignancy using large multi-center data sets and validation to improve diagnosis. I am sure Dr. Sonal Panchal will elaborate on IOTA methodology, which will benefit all of us. I would like to hear her, what she is going to tell us. Now, the management of ovarian masses will depend on whether benign or malignant, observation for benign cyst and removal if it does not regress and grows larger, or if more than 5 centimeters. For malignant ovarian masses, multidisciplinary approach is required. The primary treatment is hysterectomy and bilateral salpingo-oophorectomy. Add-on therapy with chemotherapy, radiation therapy, targeted therapy, and immunotherapy may be required. Dr. Jyoti Jaiswal will highlight the management options. Now, the most difficult ones to manage are the gray zones ones in ovarian masses, and I'm confident that learned Dr. Girjawa will come up with solution for this problem with her knowledgeable panelists. This webinar will definitely benefit all of us, updating our understanding and management of ovarian masses. I thank the organizers for inviting me to such a knowledge-enriching webinar. Long live ISOPA. This I always say.
Thank you.
Thank you for inviting me.
Thank you, Usha Sharma ma'am. Thank you for the great words and for summarizing the program which lies ahead. And after receiving blessings from Dr. Usha Sharma, our guest of honor, we go on to introducing the Secretary of Aligarh OBGY Society, Dr. Zehra Mohsin. Dr. Zehra Mohsin, I have been associated with Madam last 2 years. I have been talking to her off and on. She is the professor and chairman at the Department of OBGY at JNMC, Aligarh Muslim University, Aligarh, and the Secretary of Aligarh OBGY Society. She has got a special interest in gynecological minimal invasive surgery and emergency obstetrics with a teaching experience spanning 3 decades. The stage is all yours, Zehra ma'am. We would like to have a few words from you.
Thank you, Dr. Monica. Thank you for having my society's participation in this program. And I'm sure it's going to be very invaluable for us to understand how important it is to preoperatively work up these lesions and to plan future management. So thank you for having us on board.
Thank you. Thank you, Zehra ma'am. And we know what a great academic background AMU has with a leader like you and a teacher like you. And next, I would like to invite and welcome the Gorakhpur OBGY Society President and Secretary, Dr. Dipti Chaturvedi Madam and Dr. Upma Yadav Jaiswal. Are they there, Purva? I think Madam will be joining later. We will introduce when Madam joins, and Dr. Upma also. Next, we have already introduced our President Merit OBGY Society, and Madam is also President of Merit Menopause Society, ISOPAP Society, Dr. Bharti Maheshwari. She is so active in all the organizations, and we welcome her not only as a guest of honor, but also the President of our participating Foxy Society. Dr. Priyanka Garg is her dynamic secretary. I think she is yet to join. So we again give our regards to Dr. A.K. Chaturvedi, who is president of the OIRF, the Onco Integrated Research Foundation, where surgeons and gynecologists get together to give the best radiation therapy to our ovarian cancer patients. So with this, I come to the co-convener. My co-convener is Dr. Randhir Singh, Managing Committee Member of ISAR, as well as the Vice President of Bhopal ISOPAP chapter. And we have 3 coordinators with us. Dr. Purva Bhatkur, who is Assistant Professor GMC Bhopal. She has been calling all of you. And Dr. Ankita Upadhyay, who is Assistant Professor at Chirayu Medical College, Bhopal. Both are very, very active and keen academicians. Dr. Nandini Singh Bhati is right now on a vacation, on leave. So we start the program with Purva, and she can begin with session 1 because Dr. Sonal has been waiting for a long time.
So we do our first academic session that is on OUTA methodology. I invite Chairperson Dr. Meenakshi Sood Madam, Dr. Zehra Mohsin Madam, and Dr. Upma Yadav Jaiswal Madam. Dr. Meenakshi Sood Madam, Madam is presently the President of Aligarh OBGY.
I think it's done. Let's go to the academic session speedily.
Okay.
Right. I will introduce, my great pleasure to introduce this charming lady, Dr. Sonal Panchal, who is an esteemed speaker today. She is consultant Dr. Nagri's Institute for Infertility and IVF, Ahmedabad. PhD in ultrasound in gynecology and infertility. She's master ultrasound in OBGYN, Ian Donald InterVarsity School of Medical Ultrasounds. She is Professor Dubrovnik International University. She is the National Academic Director, Ian Donald School, India. She is Director, Center of Excellence, Ian Donald InterVarsity School of Medical Ultrasound, Ahmedabad. She is in National Advisory Board member for International Journal of Infertility and Fetal Medicine, JP publication. She's the reviewer for Journal of Human Reproductive Sciences. She published 45 papers in national and international journals and delivered more than 800 lectures, contributed in authored several books, more than 120 chapters, and she has keen interest in infertility, gynec ultrasound, 3D and 4D ultrasound. I think which is she's going to tell us how the aorta we can, include in our day-to-day practice of making ovarian masses, be they be benign, malignant, or inconclusive. Thank you, Dr. Sonal. Please go ahead.
Thank you very much, ma'am, for those very kind words. And it is definitely a pleasure. Monica, your invitation, nobody can deny. And your hard work is seen everywhere. Thank you very much. And I right away start with the presentation. I hope my slides are visible and I'm properly audible.
Yes, ma'am, you are.
To start with the aorta terminology, aorta consensus, it is basically about terminology, about simple descriptors and simple rules. Yeah, so the basic questions, whenever you see any adnexal mass, is one, whether it is ovarian or it is extra-ovarian. Whether if it is ovarian, then it is functional or it is a pathological. And then if it is pathological, is it benign or malignant? And finally, the specific diagnosis. So starting with the first one, which is ovarian or extra-ovarian, there are two important signs which we need to elicit whenever we see any adnexal mass, and for that matter, for any mass in the body or even in any lesion. If you're talking about reproductive medicine or gynecology, only the uterus or ovary, you have to locate the structure of interest or the mass. Oh, I don't know why this. Okay. So you have to locate the structure, the organ and the lesion, and then you're going to do an in and out movement of the probe. And with the in and out movement of the probe, if you can separate the two, I'm sorry, that clip, I don't know why it's not working, but yeah. So if you can separate the two, that's when you know that the lesion is arising out of the ovary. Whereas if you cannot separate the two, it is either arising from outside the, it is either arising from the ovary or it is adherent to the ovary. So sliding organ sign positive, you can slide the two, you can separate the two, which means that it is extra ovarian. Whereas if your sliding organ sign is negative, you will look for either a rim of the ovarian tissue or you will see a beak of ovarian tissue. If you see one of these two, that means that the lesion is intra-ovarian. But your sliding organ sign is also negative and your rim or beak sign is also negative, which means that the lesion is arising from outside the ovary, but it is adherent to the ovary. That means that with these two signs, you can find out what is the origin of the lesion. Following that, the second question, whether, because it's ovarian, is it functional or it is pathological? We know that ovary is a home to several cystic lesions, and they are all, and majority of them are arising out of normal or abnormal physiology. And when it is arising out of normal or abnormal physiology, that's when we call it a functional cyst or a functional lesion. And when it is not related to the normal or abnormal function, it is a pathological lesion. It is therefore essential that whenever you are assessing any adnexal lesion, you must have information about the phase of the menstrual cycle and any drugs that have been taken for ovulation induction or delaying the periods or any hormonal intake which would disturb or which would affect the normal reproductive endocrinology. A thorough knowledge of the classical appearances of the physiological structures like follicle, corpus luteum, etc. is essential. And lastly, The final question is whether, if it is inside the ovary, if it is pathological, is it benign or malignant in origin? And then finally comes the specific diagnosis. When we come to specific diagnosis and we are thinking in terms of the various tumor masses, which appear as either solid masses or as complex cysts, as it is commonly said, you may divide these lesions into borderline tumors, metastatic tumors, or benign tumors. And it's very interesting to see here that the majority of the lesions are benign lesions. And this is a very important piece of information. Why I'm saying this is we know that whenever a mass is seen in the ovary, a cystic mass or maybe a complex mass, that's when the first thing we want to do is to think that it is malignant, and many times we may be therefore intervening into the masses which are actually absolutely benign and may not even be of significance. Yes, it is true that it's very important, therefore, to differentiate between benign and malignant masses, because in the hope that, in a good hope that it is a benign lesion, we cannot leave the malignant lesions untreated, and therefore this discussion on aorta. If we say the mass is there and it is pathological, we must differentiate into at least 4 groups if we don't come to the specific diagnosis, which is benign ovarian, benign non-ovarian, primary malignant ovarian, and secondary malignant ovarian. That means you need to find out whether it's a benign mass or it is a mass which is primarily arising from the ovary, or it is a secondary deposit in the ovary. Starting with the benign ovarian masses, there's a long list, and maybe polycystic ovaries, though, is not a mass, but sometimes it does appear like absolutely solid looking ovaries. This is when the polycystic ovarian syndrome is very severe. That's when the follicles are compressed by the expanding stroma and they may not even be seen, and therefore sometimes the polycystic ovaries may be documented as benign tumors. There may be functional cysts, there may be endometriomas, serous cyst adenomas, mucinous cyst adenomas, mature teratomas, fibromas, and thecomas. So these are the tumors which are mostly benign, and they are very commonly seen. We need to also differentiate between the non-ovarian masses, but still they are benign, and there would be paratubal cyst, para-ovarian cyst. There may be a tubo-ovarian mass, there may be hydrosalpinges, peritoneal pseudocysts, appendiceal masses, diverticular abscesses, and pelvic kidneys. Why I am showing this list, or why I am enumerating them, is it is very, very important that we always keep in mind these lesions which we see commonly, but in the fear of coming across malignant lesions or not missing malignant lesions, we often do not think about these lesions, which is very, very important. Moreover, as a gynecologist, when I'm talking about this list, as a gynecologist, we would only think about ovarian or the tubal or the uterine masses, at the most the vaginal or the cervical masses, but the masses that arise from the close neighborhood of these reproductive organs are often not even thought of. Primary malignant tumors, chiefly epithelial carcinomas, germ cell tumors, and the sex cord tumors. Yes, it is true that we usually only think about the epithelial tumors, and in the malignant group of the epithelial tumors, maybe borderline or actual malignant lesions, cyst adenocarcinoma, serous cyst adenocarcinoma, mucinous cyst adenocarcinoma, endometrioid carcinomas, and clear cell carcinomas. Yes, it is true that these are the names that we usually read in the histopatho, but some of them really have a very specific appearance on the ultrasound, and therefore, even on ultrasound, you can strongly suspect a lesion before you, the type of the lesion before you go into a biopsy and a final diagnosis. Granulosa cell tumors are a very important group of lesions which need to be identified correctly. These, if not diagnosed, it may for sure be feared as malignant tumors, looking at its appearances. And moreover, also being associated with the endometrial hyperplasias. Secondary malignance may be 10% of the ovarian malignancies, chiefly from the breast and the gastrointestinal tract. So this is the list of the lesions that we want to fairly confidently differentiate on ultrasound. Of course, histopatho is going to be a final diagnosis always. And to do this, it is essential first to understand about the IOTA guidelines or the IOTA consensus. In this, we would go across a few points. First is the correct terminology for description. And this is very, very important, I tell you, because we usually use random terms. We use the terms that comes to our mind as routine literature descriptions. And it is in this case that the same lesion we would be describing in different ways at different points of time. And therefore, we would confuse not only the lesions of, we would not only confuse the types of lesions when it has been reported by other people, but even there is a lot of intra-observer confusion occurring when we assess these lesions at different points of time. The second is easy descriptors and pattern recognition, simple rules, logistic regression, and of course, final is always the expert opinion. We would start with the terminology first. And when we talk about terminology, it is about the IOTA group, the terms and definitions of the adnexal pathology, and what are the terms that we will use for the during the reporting the transvaginal ultrasound. Starting with these descriptions and definitions. What are the things that we are going to define? We are going to define what is a septum, when to call a lesion a septated lesion, or what is a septum, solid projection or a papillary projection or a wall irregularity needs to be differentiated. Cyst contents, whether it is anechoic, low level, ground glass, hemorrhagic, or mixed. We will also document what exactly we mean by wall irregularity, which is mentioned with the solid projections also. The shadows, we know, we come across a lot of acoustic shadows when we are seeing ovarian masses, especially dermoids, etc. Presence of ascites, and of course, finally, the texture or the morphology of the lesion, which we would differentiate as unilocular solid, multilocular solid, or solid. So let's start with the first one, and that is the septum. When do you call when do you report a septum? When you see a thin strand of tissue running across the cystic cavity from one to another internal surface of the cyst, if it touches both the ends, both its end touches the cystic wall, that's when you call it a complete septum. In one or more sections, if it appears not extending to the opposite wall, very importantly, not in all the sections, but even in one section, it is not reaching the opposite wall, it is an incomplete septum. That means that whenever you report a septum, it is important that if you've seen a septum, you're going to do a longitudinal scroll and a transverse scroll and observe the septum very closely. It has to touch, both its ends have to touch the cyst wall to call it a complete septum. If not, you report it as an incomplete septum. So that is a septum touching one wall, but here and here also, it's actually touching here. There's a slight slightly thinner here in this part, and therefore there's still a complete septum. Here, this septum, you may call it complete, but it will be important to report that on one end, it is touching the cyst, but on the other end, it bifurcates, and then it is dividing the cavity. And of course, you may also have incomplete septum. As you're seeing here, this is probably a septum-like structure, but you don't have a part of the septum seen here. And this is not just thinning, because there is a broadening of the end here, which tells it is a sort of a stump there, and it is an incomplete septum. You call it a septum to be a thin septum if its thickness is less than 3 millimeters, and you call it a thick septum if it is more than 3 millimeters. And remember, the septum is never measured at the ends, it is measured in the central part. The thickness of the septum, the maximum thickness of the septum at any point other than its interface with the cyst wall is the way you measure the thickness of the septum. Measurement is taken when the septum appears perpendicular or oblique to the ultrasound beam and not parallel. That means that if you were seeing septum not horizontally or obliquely, if you're seeing it vertically, that's when you do not report the thickness of the septum, because when that happens, that's when the sound beam passes parallelly through the entire length of the septum. There is all refraction, no reflection, and therefore the thickness would always be overmeasured. Coming to, so again, there are septums in there, and there are multiple septa here. As you can see, you need to scroll across and find out the number of locules whenever there are septum, and that's when you would report it is single septum or there are multiple septum, and approximately how many locules. But apart from that, this clip actually shows you low label internal echogenicities, as you can see. So internal echogenicities, whenever you see, it may be due to clots or maybe due to fibrin strengths. And this can be differentiated from the septum by the concavity of the margins due to clot retraction. And this is, again, a very important point. When we report septums, many times it happens that they are not septum, there's only the fibrin strands which are present in all the cystic lesions which has hemorrhagic contents. And because there is blood which is clotted and then it retracts and it forms a fibrin strand, therefore, because of the retraction, whenever you scroll across a fibrin strand at any one point, if you see that there is concavity of the margin, that is what tells us it is a fibrin strand and it is not a septum. Say, for example, if you're working on this cystic lesion slowly, we would start seeing it. This appears to be an absolutely straight line. That also appears to be a straight line. But as we scroll across, yes, you are seeing a slight concavity here, which raises a doubt. This may be a fibrin strand, and this also is a concavity which tells us this also may be a fibrin strand. Similarly, another concavity here also. So it did feel in the beginning that it is probably a multiseptated lesion, but looking at every individual strand-like structure closely, it clearly appears like fibrin strand, even here. So this concavities tell us it is a fibrin strand and it is not a septum. There is one opinion that if it is thinner, it is more likely to be a fibrin strand. If it is thicker, it is a septum, but probably that thickness has no definite cutoff, and therefore we probably will not use that as a guideline to differentiate between a fibrin and a fibrin strand and a septum. Coming to the second point, so we know exactly what is a septum. Coming to the second point, and that is solid component or solid projection. It exhibits a high echogenicity, suggesting presence of tissues like myometrium, ovarian stroma, or fibroids. Of course, if it is in the ovary, it is not going to be fibroids. If at all, it may be a fibroma. It is not even going to be myometrium. But the point tell is the echogenicity of the same is echogenicity of it is similar to myometrium, or it is similar to fibroids, or it is same as that of an ovarian stroma, or it may even be hyperechoic to it. Irregular thick wall, regular septa, or normal ovarian tissue is not considered a solid tissue. That means If you have a cystic lesion which has irregular walls, thick and irregular walls, which has septa or has normal ovarian tissue inside the lesion, this is when you do not call it a solid projection. To confirm it's a normal ovarian tissue, it should show follicles. And septum, we already have defined, and irregular thick walls, we know very well. It would be a thicker wall with irregular margins inside. The inner margins are irregular. Though in case of doubt, the blood clot or the solid component, it is considered a solid component. That means if you are not sure whether the solid area seen or the solid part seen in the cystic lesion is a blood clot or a blood product or a debris, or it is a solid, actual solid projection, it would be best to always consider it as a solid projection or a solid component so that you would assess the risk to its maximum and take actions to treat it. If you consider it as a blood clot, if you're not sure and you consider it still as a blood clot or a debris, you are going to leave it alone. So please don't do that. Consider it as the worst possible prognosticating feature and treat it accordingly. It is here very important to understand that if it is a debris or a blood clot which is not strongly adherent to the cyst wall, that is when, if you do an in and out movement of the probe, again eliciting the so-called sliding organ sign, if it is a debris or a blood clot, it would move inside the cyst where it's the solid projection, its correlation, its relation with the ovarian, the cystic lesion does not change, which confirms your diagnosis, it is a solid projection. Moreover, if you put on a Doppler, and if you can see flow inside, it again confirms it is a solid projection and it is not a debris. Say, for example, here you are seeing a large solid component with markedly irregular walls. And this is here shown on the 3D ultrasound, where you can again confirm the irregular walls of the solid projection and the cystic component of the cyst here. The solid projections can be differentiated, as I told you, from the clot or debris by not only the sliding organ sign, but more commonly, I said more commonly, not always, the solid projections have convexity inside the cyst lumen, whereas debris is usually, it is flat surface and it settles based on the gravity. But it is also possible that the solid projections may only appear as a plaque throughout the inner wall of the cystic lesion. Reflective avascular area in the center of the dermoid is not a solid projection, or sludge in the internal walls, on the internal walls, is also not a solid projection. Coming to the papillary projection, of course, papillary projection is also a solid projection, but this is a solid projection which has a height of less than 3 millimeters. If it is the height of more than 3 millimeters, that's when you call it a solid projections. If it is less than 3 millimeters, that's when you call it a papillary projection. In cases of cystic lesions with small diameter, in case of cystic lesions with small diameter, there may be confusion between the incomplete septum and the papillary projections, and these must be considered as solid papillary projections and not incomplete septum. This may give you a graver prognosis and better chance to treat those lesions. This applies for hydrosalpinges also in the cogwheel appearance, as you're seeing there. And then going to the next one, papillary projection, I've already told you the height. It is important to understand that the papillary projection is a solid component, but every solid, but a solid component is not always a papillary projection. The measurement of any solid projection is to be taken in 3 orthogonal diameters. Take the maximum diameter, mean diameter, and the volume. So it is this way that you usually measure it. We are going to that figure in a minute. Before that, let us read the description. The papillary projection is measured as height from the inner margin of the wall to the upper margin of the solid projection or the papillary projection, and the breadth of the base is measured. So this is how we are going to measure it. If you have a papillary projection here, this is the wall that is that would have been present. So mark the continuity, and from there the maximum height is the height, and from one end to the other end, the part of the solid projection which is attached to the cyst wall is the base. Number of papillary projections should always be mentioned. The number of solid projections also need to be mentioned. The size of each needs to be mentioned, and the details of the vascularity of each. Internal wall of the cystic lesion is described as smooth or irregular. So coming to the next descriptive point, naturally a solid projection makes it irregular. Any irregularity, therefore, needs to be mentioned as either solid projection more than 3 millimeters in height, papillary projections 1 to 3 millimeter in height, and lesser than that is an irregular wall. So you have a nice smooth regular wall, you have irregular wall with papillary projections, and this is just an irregular wall. External wall also needs to be mentioned, especially when it is solid lesion. When you are describing walls for cystic lesions, you describe the smoothness or the texture of the inner wall. And when it is solid lesions, you mention it about the outer walls. The contents of the cystic lesion, anechoic, we all know what is anechoic, low-level echos like mucinous tumors and amniotic fluid, ground glass echogenicity, hemorrhagic echogenicies, by which we mean fibrin strands, cobweb pattern, honeycomb pattern, fishnet pattern, jelly-like pattern, or star-shaped strands. And of course, mixed, which is hyper and hypoechoic cystic contents. So that is completely anechoic, that is low level, that is ground glass. And then this is the fibrin strands, and this is the debris, this is this is the last one is hyper and hypoechoic. So that is about the contents of the lesion. Mixed cystic lesion. What do we mean by mixed cystic lesion? They are mixed. That means they may have fat and fluid level, or there may be an abscess where there's a solid component and a cystic components. For that matter, you may also have, as we mentioned earlier, if you have solid component in the dermoid, which is actually not a solid projection, may also be put into this group and call it a mixed cystic lesion. And of course, we know that when we have sebaceous cysts, say for example, even dermoids for that matter, you have a fat layer and you have a fluid level. And so those are all where the contents are mixed, you call it mixed cyst. Acoustic shadowing, you all know very well, posterior to or deep to the severely hyperechoic areas like teeth or bones, you see shadowing, black shadowing, which is because this solid components, they eat up all the sound waves, and it doesn't pass posteriorly, and this is called acoustic shadowing, loss of acoustic shadowing behind the sound absorbing the structure is the definition. Ascites, fluid outside the pouch of Douglas, is all ascites. And then coming to the final thing, and which is a little tricky and very important, and that is unilocular, also includes lesions with incomplete septa, unilocular solid, multilocular solid, solid and non-classifiable. What is unilocular? A cystic lesion with no septum or incomplete septum, or no solid component also. So no solid component, no septum, or just an incomplete septum. These are all unilocular cysts. Here, this is the second one. This is not the, this is the incomplete septum. So this is also unilocular. That is unilocular. That is unilocular. Coming to the unilocular solid, if there is a unilocular cyst but has even a small solid component, it is called a unilocular solid cyst. So at least one papillary structure or a solid component, it makes it a unilocular solid. Multilocular, where you have multiple septae, as you can see in both the solutions, but there's no solid component that is a multilocular cyst. At least one septum is important. So even it can be just a bilocular, but it can be multilocular also. For multilocular cysts, count the number of locules, and that is important, which I mentioned earlier also, and this may sometimes require a 3D ultrasound. Multilocular solid, that means it's a multilocular lesion, but there's also a solid component in it, and which may be even as small as a papillary projection, but this is multilocular solid. Solid lesions, when the solid component is more than 80% of the total content of the lesion, and therefore I would not, I mean, because the solid component is more than 80%, I would not call it a cystic lesion here. Non-classifiable, maybe because of poor visualization, or because of strong acoustic shadowing, or because of opacity. So when you cannot assess it adequately, that's when you report it as non-classifiable. Why is this final point important? The texture or the morphology of the lesion is because it is closely related to the possibility of malignancy. For example, if it is unilocular cyst, the chances of malignancy is very, very minimal, just about 0.6%. Whereas whenever the solid component, if it is multilocular, again 10% only. But when the solid component is added, say for example here unilocular solid, the chances of malignancy increase to 37%. If it is multilocular solid, 43%. And if it is a pure solid tumor, 65%. That means the presence of solid component is a very important thing to be reported, because that is what is definitely going to affect the risk of malignancy. It is for this reason that whenever you see any lesion in the ovary, you must have a very keen complete look of the lesion by a complete longitudinal sweep and a complete transverse sweep, both done very carefully and attentively. Vascularity is the next important thing to be reported when you're seeing any of the adnexal lesions, and the vascularity score is given as follows. Of course, this is a bit subjective, but it is still, I mean, it works like that way. And this is the same not only for the IOTA, for AITA, for MUSA, for all different consensuses. This vascularity score remains the same. If there's no flow, you call it vascular score 1. Minimal flow is vascular score 2. Moderate flow is vascular score 3. And strong flow is vascularity score 4. Remember that for all these, for reporting the vascularity score, your color and the power Doppler PRF should be 0.3. If you're using velocity scale instead of PRF, it should be between 3 to 6 centimeters per second. The balance should be set at 220, and adjust the Doppler gains to just below the artifact level. Several areas in the tumor may be sampled, and subjective or semi-quantitative assessment as vascularity scores must be documented. Document the results with highest time averaged maximum velocity, which is called TAMXV. This would appear on your screen as you do the measurements for the Doppler, and corresponding PI, RI, and the PSVs. So that is the terminology. Coming to the next point, and that is simple rules of IOTA. So much of description, but then how do I know whether it's benign or malignant? And it's very simple. If it is unilocular, if there is a solid component, the largest diameter of it is less than 7 millimeter. There's acoustic shadowing. There's smooth, and if it is not unilocular, it's multilocular, but it is smaller than 10 centimeters. And there's no blood flow. That's when you would know that it is a benign tumor. Whereas and these are the features of the benign tumors. It is unilocular, it is acoustic shadowing, it is septa, but it doesn't have any solid component, and it doesn't have vascularity. And if at all solid component is there, the measurement is less than 7 millimeters, tells you, yes, it is a benign tumor. Coming to the malignant tumors, when do you suspect or when do you strongly fear a malignant tumor? If it is irregular solid tumor, there's ascites, there's a lot of vascularity, it is multilocular solid, and it has at least 4 papillary structures, that's when you strongly suspect malignancy. So again, there's a large solid component, multiple papillary projections with irregular walls, a lot of vascularity, and of course, so again, a lot of solid component. That's when you would, and presence of ascites, that's when you suspect malignancy. If you have one or more benign features, it is a benign lesion. If you have one or more malignant features, it's a malignant lesion. But if you have both the features, 1 or 2 features from both, that's when you put it as inconclusive, and that's when you apply logistic regression, which is appear with a software with a consensus. IHR simple rules can be used to classify some of the, so 75% of the adnexal masses as benign or malignant. For masses not fitting in the simple rules, proceed to 2-stage strategy, proceeding to the expert opinion finally, and that is considered as the final opinion. Valuable alternative to simple rules is logistic regression too, and it has an advantage that it is applicable for the entire tumor population and produces risk assessment for the malignancies. If it doesn't fall into, I mean, if you have used simple rules, but you are still there's still some more definitive criteria, and that is about the pattern recognition. Pattern recognition has a sensitivity of 92% and specificity of 93%. And these are very, very clear and simple. Say, for example, it is an endometrioma. You would automatically know it is an endometrioma if it is a unilocular tumor, ground glass echogenicity, which all of you know. A unilocular tumor with regular walls, maximum diameter of the lesion less than 10 centimeters, simple cyst mostly, or simple cyst, cystadenoma. That is multiple fibrin strands, and you know that it has regular walls. So that is also a benign lesion, and this may be just fibrin or fibrin strands. And whereas this one, where you have a lot of vascularity, you would consider it as a malignant lesion. So that means, of course, I will not go into all the definitions of this, but endometriomas, you know, ground glass benign cystic teratomas, you know, you may have low-level echogenicities, you may have hyperechoic areas with acoustic shadowing, you may have fat and fluid levels, and so on. And this is a pure 2D diagnosis. Simple cyst, we have discussed. Cystadenoma, we have discussed. Functional cyst, hemorrhagic cyst, again, we have seen. Fibroma, usually solid tumors, as you have seen here. So that is about it. But if this don't help, that is when you use the logistic regression, which uses age, ascites, flow in the solid papillary projection, maximum diameter of the solid component, irregular internal walls, and the acoustic shadows. So these are the features when you assess, and you need to use your I mean, these are the features that you need to assess when you are using logistic regression 2. Of course, there's a logistic regression 1, but the variables used in that are many more. This is more convenient. So you need to fill up into a model in a logistic regression model. There's description, there's points, and it tells you what is the risk of malignancy. If you're using only simple descriptors, you can diagnose 43% of the lesions. If you're using simple rules, 75%. You can differentiate between benign and malignant, and logistic regression leads to increased diagnostic performance. So that is a 3-stage approach that we usually take. If you go to the actual algorithm, when you see an adnexal mass, that's when you can use logistic regression 1 or 2. That would tell you it is benign or malignant. If it is malignant, must be considered to the, must be referred to the oncoclinic, and otherwise conservative management. Simple rules, if you have used, that's when inconclusive, benign, malignant. We have already read about the simple rules. If it is benign, treat conservatively, but if it is inconclusive, that's when expert opinion is important. So finally, it is an expert opinion which works. And this is, apart from this, you can also use it much more comfortably when you use adnex models. These are models which are sort of your phone apps, and this can be very easily used. You can download it on your mobile phones, even with your after doing your ARTA courses and getting the certificates. And you just need to mention the age, the maximum diameter of the lesion, maximum diameter of the solid part, cystic locules, Number of papillary projections, acoustic shadowing, ascites, and serum CA125. And based on this, the model automatically calculates the risk of malignancy. Malignant ovarian tumor, the risk of malignant tumor. So this is how you get the report. So you can confidently differentiate between the malignant and the benign, at least high risk malignant and benign tumors. And that is how you can use that Nexel tumor. But there's something very important which I need to add here. IOTA has been there for many, many years, but IOTA has been challenged, or maybe I would say has now been competed by another system of differentiating and suggesting the management of the ovarian lesions, and that is what is called ORADS. Of course, this is more used by radiologists as compared to the gynecologists, but this is also a very useful method, and this is also related to the IOTA model. It appears to be a little more simpler and easy to apply. I'm not going to read out it all, but you can see here very clearly the green is benign and it is no risk, low risk here, high risk, and it also tells you what would be the management strategy for the individual lesion. Say, for example, simple says less than 3 centimeters, more than 3 centimeters, 3 to 5, and 5 to 10 centimeters, and so on. So it's very, very useful to practically. And that also can be used if IOTA is if IOTA leads to an inconclusive report or doesn't really lead you to any conclusion. Of course, expert opinion is the best and the supreme. But yes, even ORADS along with the IOTA can be used to differentiate between the adnexal lesions. Thank you very much for that patient hearing.
Zehra madam, I think you have chaired the session, and Upma madam, please kindly give the closing comments. Our speaker has just finished her talk. Zehra ma'am, please unmute.
So madam very clearly defined each and every aspect of how to apply the IOTA rules. And it is very important because ultrasound being a very basic and the initial imaging modality, I feel it is very important that each of us should understand these rules very well for working up our patients before we plan any sort of management. Because we all understand that in case we plan minimal invasive surgery, which most of us might not be, we might not be very expert at in a malignant lesion, then we definitely will upstage the disease. So I think we all understood. Thank you, madam, for a very clear and lucid lecture and enabling us to understand how to evaluate each and every aspect of the ovarian mass. So thank you so much.
Thank you.
Dr. Upma madam, would you like to speak a few words?
Yes, ma'am. Ma'am has always been a legend for us, and we always look up to her for so many things. She has been a teacher beyond excellence, and what should I say, ma'am, just a pioneer and teaching us. She's the best mentor of ultrasound, transvaginal ultrasound, especially for whole India, I would like to say rather.
Thank you. Thank you very much. Thank you very much.
She's like so mesmerized by her talks.
Madam, Sonal ma'am, I had one quick question for you.
Tell me.
Madam, like in FIGO classification of fibroids, now we've started mentioning the type of myoma, whether it is FIGO 1, 2, 3, 4. But in IOTA classification, suppose we see a hemorrhagic cyst measuring 3.5 centimeter with a retracting clot, thin walls. How do we mention it by IOTA terminology in our gynecology?
IOTA, actually, this is a very important and a very nice question, Monica, because what is generally thought is any lesion you see in the ovary or the adnexa, you have to apply IOTA. Probably no, because IOTA comes into picture when you are not sure or the lesion is not typical. So if, for example, if it's an endometrioma, that means it doesn't fit into the pattern recognition. Say, for example, you have a cystic lesion with ground glass echogenicity, some flecks of hyperechogenicity in the walls and painful on pressure and short course vessels. Everybody knows it's an endometrioma. Say, for example, there is a cystic lesion which has isoechoic, thick, irregular walls and internal hemorrhagic echogenicities. You know that it's a corpus luteum. But when it doesn't fit into this all known pattern recognition categories, that's when you apply iota. And that means that iota has a role when you are not sure what the lesion is and you want to adequately or optimally assess that patient or put her or triage her into, whether it is malignant or benign, and then lead to the final management. So it is very important. Iota is not to be applied to every cystic lesion that you see. And therefore, at the beginning, I mentioned you first need to differentiate the functional from the non-functional or pathological ones. And only after that, after you do define pathological, if they fit into definite pattern recognition, just separate them. And then for the rest of the lesions, you're going to apply iota.
Thank you. Thank you, madam. That was very lucid way of explaining. And this was really a doubt I had. So you cleared it, and so did your lecture.
Thank you.
So thanks, ma'am, for joining. And like always, I'm so grateful because you are such
It's my pleasure, Monica. It's
you're
my
such a good opening batsman that as soon as Sonal Panchal madam's lecture is there, the webinar is already a super hit.
Please don't say that. That makes me nervous. Thank you.
So much. Thank you so much, ma'am, from Synergy team.
Thank you.
So, Dr. Purva, I think Jyoti Jaiswal madam is waiting. So let's start the second session.
So moving to our second session, that is on the management of ovarian masses, how to read between the lines. To chair the session, we have Dr. Monica Singh ma'am, Dr. Deepti Chaturvedi ma'am, and Dr. Priyanka Garg ma'am. And they have not yet joined. They will be joining. And so
Purva, can you be a little louder? Purva, your voice is breaking. Can you just,
Hello?
yeah.
Yes.
Yeah.
So Dr. Monica Singh madam is presently president
Okay.
of
Okay, Purva, I'll introduce Dr. Jyoti.
GG.
So it is my honor and privilege to introduce my dear colleague and my friend, Dr. Jyoti Jaiswal from Raipur. I've always admired Dr. Jyoti for your multifarious talents, including academics, but she has got lots of, good cultural activities also she's very good at, including she's a very good dancer. So she's interested in fine arts also. But apart from that, she is heading the Department of OBGYN at Pandit GNM Medical College, Raipur, which is one of the most reputed medical colleges of the country. She's been very active in IMS, and I think you are now the president of Menopause Society.
I'm going to be the Secretary General next year, taking over as the National Secretary General, Dr. Monica, at your place only, at
Yes.
Bhopal, the next national conference.
She is very, very active in IMS, and we are hosting the IMS Con, National IMS Con of 2026 in Bhopal, the city of lakes, where she will be taking over as the post of Secretary General. So welcome, Dr. Jyoti. We look forward.
Thank you so much. Thank you so much, Dr. Monica. First of all, that this bringing together so many people to this wonderful academic platform, and the stalwarts of the nation are there, starting with the Sonal Panchal madam. Already more than 50-60% job is almost done. She has been crystal clear in letting us clarify the dilemmas and say ideally the reading between the lines work has been simplified. As you suggested me that I'm sharing my screen, Dr. Monica.
Yes, please go ahead.
And as you have suggested me that we can go ahead with the case-based condition. for this talk to clarify that if any patient comes in our OPD, and then we need to think that how we have to proceed ahead, then how we should go ahead. So evaluation and management of the adnexal masses, reading between the lines, will go with the adnexal masses. In general, if coming to you, then first you have to see the differential diagnosis. As the Sonal madam already said, that you have to understand whether it is benign, it is borderline or malignant, and if there is some confusion, then you have to clarify it and then reach towards the management approach. So similar condition to so many people comes because even in the younger women, the 6 to 7% of the 6 to 7% of 20 to 40% women have the incidental adnexal mass located on ultrasound. They do not have any complaint. They have just gone for any ultrasound or for some other reason. They have been examined and it has been found that they have some adnexal mass, and then chaos comes in the mind of the treating doctor as well as to the patient. And because this condition is dreadful as well, and sometimes it may be very, very simple. So keeping the frequent checkups are also important, because there is 5 to 10% lifetime risk to undergo surgery for suspected ovarian neoplasm. And it is for the it is a very high number that nearly 2 lakh women undergo surgery per year for the pelvic masses. But only 10% of that comes with the confirmed malignancy. So that means that a person may be unnecessary undergoing the surgeries, because even if it is benign, the surgical exploration of benign lesion is also not without the potential consequences, with reported complication rates ranging from 2 to 15%. So diagnosis is often difficult, as definitive diagnosis requires surgical evaluation. In spite of so many technologies have come, there are so many score, still the final diagnosis many a times comes with the after the surgical exploration and the histopathology. So initially we need to see that whether this mass is gynecological or non-gynecological, because this is not the forum where I should discuss about the non-gynecological. So we'll see that what gynecological conditions we can come across. Is it a functional or the paratubal cyst, fibroma, endometrioma, tubo-ovarian abscess? Even we have to think about the ectopic pregnancy, because it is one of the condition which can take life of the patient. And so it should be first clicked in our mind. Hydrosalpinx, mature teratoma, serous cystadenoma, mucinous cystadenoma. And when we see towards the malignant, the germ cell tumor, sex cord stromal tumor, and the epithelial carcinomas can be there. The epithelial carcinomas can be in the reproductive age group, the later part, as well as afterwards as well. But the germ cell tumors, they can be in the earlier form. So looking at the age, that's why in so many models, the importance of the age, importance of the CA125 after menopause, before menopause is different. So we'll proceed with the some case situations. The first case, like say, it is presented with the in the emergency department with unilateral right pelvic pain that was abrupt in onset and accompanied with nausea and vomiting. Vital signs were stable except for the tachycardia, but as the nausea and vomiting are present, it is giving us the alarm that it can be of pregnancy related things as well. The right lower quadrant tenderness is also present. So we need some additional information to clarify that what it is. Beta is the SCG test was done, which was negative. Borderline raised of the WBC, hemoglobin all right. So even when the hemoglobin is all right, these all things are negative, still the ectopic can't be ruled out. So you'll need further confirmation, and definitely ultrasound is a boon for so many things to clarify. And this picture is suggestive of that uterus is empty, there is no sac, one ovarian cystic lesion possibly with the peripheral arrangement of the follicles are there. And it is also very important that we should put the Doppler flow, color flow button should be on. If you are putting the ultrasound for the adnexal mass clearance, you need to see for the color flow. And this color flow is suggesting the Walpole sign. Absent or reduced intra-ovarian venous flow is also can be identified. Multiple small peripheral follicles can be identified in even the grayscale. Ovarian enlargement compared to the contralateral ovary. So these things are suggesting torsion. Now, torsion can be in the adolescent age group because of the enlarged ovaries, because they remain multicystic due to the hormonal imbalance as well. And it can be a polycystic ovary, it can be a dermoid, which is common in this age group. So confirm it whether what kind of ovarian mass is there which can undergo the torsion. So if the posterior enhancement beautifully suggested by Sonal madam with low level of echogenicity of part of the content, focal areas of high echogenicity, some of which also causing shadowing, can be suggestive of dermoid also. Few more conditions which enhances the chances of ovarian torsion should be kept in mind. Ovarian torsion is not a very common condition. It accounts for only 3% of the gynecological emergencies diagnosed between the younger age group, not usually after the 35 years or 40 years. In 70% of the cases, it remain in the second decade or third decade. The most likely located on the right side. The reason is not known. The risk factor associated are the ovarian enlargement greater than 6 centimeters, increased length of the ovarian ligament. Pregnancy makes the ovary is more prone for the torsion, and definitely the fertility treatments because it increases the ovarian volume by the folliculogenesis. The sensitivity of the ultrasound for diagnosis of ovarian torsion ranges from 46% to 75%. So see the sensitivity range is a very wide range and the sensitivity is not very high. So the typical signs you cannot get in each and every ultrasound. You may not have Walpole sign in each and every torsion, which is painful. Because if it is not a complete torsion, you may not have that kind of sign. So you have to keep the high suspicion and the clinical judgment, as repeatedly said by the Sonal madam, that the expert opinion is important. Similarly, here the clinical judgment is also important. So even if not a very sure condition of the torsion on the ultrasound, but if you are feeling that this condition is leading to for this patient can have the torsion, so there is not much harm in putting a laparoscope and seeing then. And if it is a torsion, detorsion can be done. The surgical management is important here because the chances of the preservation of ovary is just by the detorsion, a simpler method. Otherwise, as late you are there for the management, the damage is more and more. And still, if the ovaries color is purplish, dark or something, we do not have to remove the ovary. It catches the blood supply and gradually becomes normal. There is no point in removing such kind of ovary. That is the clinical take-home message for the ovarian torsions. Coming to the teratoma, the common mature cystic teratomas are the common condition encountered with in the early age, in the reproductive age. And as soon as it comes with the report of the mature cystic teratoma, and if the family is complete, or if one person is having one baby, the tension between the patient and the doctor remains whether to remove or not to remove. So these are most of the time incidental findings and they do not warrant immediate intervention because the malignant transformation is less than 1%. So decision making will be according to the age, according to the fertility preservation, according to the symptoms of the patient, according to the size of that mature cystic teratoma. etc., and how the patient is presenting. If the patient is presenting with the acute abdomen with the chemical peritonitis, if rupture is there, then it is an emergency and you have to go ahead with this. The other teratomas can be monodermal teratomas like stroma override. Nearly 3% of the ovarian teratomas can present like that, and predominantly the thyroid tissue remains there. So the other clinical symptoms suggest you that what it could be. The immature teratomas are very less common in comparison to the mature teratoma, only the 1% of the ovarian teratomas, and most common in the first 2 decades. It contains 3 germ cell layers, and most often they have the neural differentiation. The immature teratomas are not good and they need surgical intervention, while the mature cystic teratoma can be seen according to the different condition and can be managed or can be managed later. The ovarian masses originates from the different area of the ovary, and according to they are classified that we all know and reading since our MBBS and postgraduate time, that sex cord stroma tumors are of various types: granulosa, thecoma, fibroma, Sertoli Leydig cells, and the germs, the masses which originate from the germ cells are the dysgerminomas, yolk sac, embryonal cell carcinoma, choriocarcinoma. These germ cell tumors are commonly, specifically the dysgerminomas and the yolk sac tumor, they are common in the earlier age group. While the surface epithelium, the masses originating from the surface epithelium, like the serous mucinous, endometrioid, clear cell, and transitional cell, are comparatively present in the later age. So, coming to the germ cell tumors derived from the primordial germ cell of ovary, approximately 20 to 25% of the ovarian neoplasm, a larger number. Approximately 5% of the malignant ovarian neoplasm can be originated from the germ cell, and it is primarily in a young women between 10 to 30 years of age. Represent 70% of the neoplasm in this particular age group. So the specific test for the confirmation that whether they are the germ cell tumor, they are important. Like LDH is important for diagnosis of the dysgerminoma. Alpha fetoprotein is important for the yolk sac tumors. So when we get a young patient with a solid or the cystic mass, adnexal mass, and we think that it can, what kind of tumor it can be. So we should immediately go ahead with these tests so that we can identify that this is a younger lady, and she should be clarify that which kind of, because these dysgerminomas are very bad for her future life and for her prognosis. So we cannot take her for the granted that only CA-125. It is a common clinical practice of the young chaps that they will see the CA-125, and if CA-125 is normal, so they will not think beyond that. So it is important in the younger age group that not only CA-125 should be given, but these tests should also be given. Dysgerminomas are 2% of the all ovarian tumors, 32% of the all malignant germ cell tumors, and primarily in adolescent and young adults, but can be present at any age. So the other ages are no bar that if the young patient is, this is not a young patient, dysgerminoma cannot happen. It's not like that. They are very, very fast growing. So the clinical history that the fast growing tumor should be connected like that. Fried appearance on pathology that can come later on, but these the upper points are for your clinical judgment. And if a patient diagnosed with the Swyer syndrome or the Mosaic-Turner chromosomal analysis, these patients are very prone for the dysgerminomas, and prophylactic removal of the streak gonads is recommended in those cases for the prevention of this condition. Coming to the yolk sac tumor, this is also common in the young, and we have some cases of the yolk sac tumor with the very young girls, and this is also a very fast growing tumor. 14 to 20% of the girls germ cell tumor. Average age of diagnosis is 20-25 years. Schiller-Duval bodies on the histopathology we can find. And very important thing that AFP elevation remains there. So always give these tests whenever a young patient with the adnexal mass, especially for the solid component. Ovarian choriocarcinoma, a very rare compared to gestational choriocarcinoma, histologically identified to gestational choriocarcinoma, but the origin from the ovary remains rare. Early hematogenous spread is associated with ovarian choriocarcinoma. So early diagnosis and early management is important. And this is relatively chemo-resistant. So the surgical management is important to prevent the recurrence and the bad outcomes. Sex cord stromal tumor arise from cells surrounding the oocytes. It may produce hormones. They are sex cord cells. Incidence is comparatively lower, 0.2 per 1 lakh, and comprises 1.2% of the ovarian malignancies. But these, in comparison to others, majority are benign, and average age of presentation is also towards the later age. These can be Sertoli-Leydig tumors, granulosa cell tumors, fibromas, and fibrothecomas. And they are predominantly producing the hormone-producing cells. So the symptoms are also associated with whatever hormone they are producing. Like if the Sertoli-Leydig cell tumor is there, so signs of virilization, signs of the testosterone dominance will be there. If the granulosa cell tumor is there, so more predominantly estrogen inhibin component will be there. There may be fibromas and fibrothecomas which present in a different way. Fibromas, fibrothecomas are hormone producing, and fibromas are irritating. So they causes the formation, the irritation in the peritoneal cavity, and usually they are associated with the ascites. Sertoli-Leydig neoplasm, they are common in the second and third decade of life. They produce androgens, result in virilization. So when you operate them, even the recurrence is not very rare. So the follow-up is important here. So follow testosterone for recurrence. If total testosterone is more than 150 nanogram per DL on clinical evaluation, or you find virilization, the ultrasound and the proper follow-up and all the imaging is important for the for seeing the recurrence of these cases. The granulosa theca cell tumors are usually present in a juvenile time. The Kohl-Exner bodies and the coffee bean nuclei are pathognomonic for this. Estrogen excess is predominant, and the young girls with the estrogen axis with the solid component, they are usually the granulosa theca cell tumors. Theca cell produce androstenedione, and granulosa cells convert this to estradiol. This may present with menorrhagia, menorrhagia, bleeding, precocious puberty. The endometrial biopsy will detect hyperplasia in up to the 50% of the cases, and carcinoma in up to 10% of the cases. So the early treatment of these patients are again important. Most common type of sex cord stromal malignancies are granulosa theca cell tumors, and they constitute for up to 5% of all malignancies. So here the tumor markers are important, that is inhibin A, inhibin B, estradiol, and AMH. So when you encounter and you are having suspicion, these tumor markers are important to give to the patient. Fibromas are producing the Meigs syndrome, ovarian fibroma and ascites in the hydrothorax or ascites. One component or both component can be there. Ascites occurs in up to 15% of these neoplasms, and they may also contain theca cell termed fibrothecoma. It contains theca cells, may produce estrogen also. So only fibroma will not produce hormones, but fibrothecoma will produce hormone and can present with the hormone producing tumor as well. Coming to the epithelial cell tumors, the most common type of neoplasm, day in and day out, maximum time what we come across, they are the epithelial cell tumors, but they are not very common in the younger age group. So if in a younger age group, something is there, so tests are different. In the older age, tests are different. Benign conditions are serous cystadenoma, mucinous cystadenoma, and more likely to be larger and multiloculated. Mucinous cystadenomas have a particular tendency of multiseptations. Like the serous cystadenomas are not so commonly multicystic, but if they are benign, but the mucinous cystadenoma, even if they are benign, they remain multiloculated with the thin walls. They have the borderline or malignant potentials, and we have in detail learned about the features for the malignant epithelial cell tumors. Diagnosis, they can be diagnosed from whatever area they are originated, or whatever type of cells are active. According to that, they are having serous, mucinous, endometrioid, clear cell, and Brenner cell type. Now coming to the benign adnexal mass, which has the simple cyst. So there is a common consensus that up to 6 centimeter may be safely monitored during repeat imaging without surgical intervention, even in the postmenopausal patients. But in the younger patient, even up to the 5 to 10 centimeter size of the simple cyst can be monitored if immediate intervention is not required. Now there are for the just keeping them under monitoring, or just we need to go for the surgical intervention. There is a dilemma in these conditions, especially where the cysts are between 6 centimeter to 10 centimeter, because the operative interference is definitely having their own issues because of the operative interference. Like the cystectomy, if we are going, it is not always that nothing can happen. And if we leave also these patients on the follow-up, that is also a problem, because not only of the malignant conversion problem is there, the chances of torsion problem also remains there, and chances of recurrence also remains there. There are in my experience, I have seen that a very simple cyst that has been aspirated by the sonologist various times, and it again and again the patient comes back with the refilling of that cyst. So those conditions can happen. So depending on the patient's choice and the clinical presentation, if the recurrence is very common, so cystectomy is comparatively better to offer towards a larger side of the adnexal cyst. And we can obviously counsel the patient about the symptoms of the torsion, and about the early intervention is needed for such conditions, so that if a patient is on the observation side, she can seek the help as soon as possible if she encounters any problem. There may be some endometriomas, mature teratomas, and hydrosalpinx, which also do not immediately warrants any treatment, and they also be managed expectantly. Because in the endometriomas, now the dictum is not a very frequent surgeries. The endometrioma, which is very, very symptomatic, only needs surgical management. Otherwise, it can be managed with the medical management. And depending on the age, depending on the family, completion of the family, means the fertility issues, the management can be decided. So the expectant management can be done for the endometrioma, mature teratoma, and hydrosalpinx. Repeat ultrasound is recommended when diagnosis is uncertain, or the we can have the confusion that this patient may not be a simple benign thing, or can have some malignant potential, or the patient becomes more symptomatic. In all such conditions, the repeats imaging and the management is suggested. The ideal interval and duration for the follow-up has yet to be defined. There is no fixed protocol that this patient should be done every 3 monthly, or every 6 monthly, or yearly. follow-up. Depending on the clinical judgment and the patient's convenience, we used to give the follow-up to them. If symptomatic, may consider for the laparoscopic cystectomy. I will not go for the aorta. Madam has beautifully covered this whole thing. So I am just skipping the whole part of the aorta. Now, again, for the reading between the lines, there are some things that are required, like the sign symptoms of the malignancy. So really its relation with the age. Age is the most important risk factor for ovarian malignancy. The CA-125 levels are very important to understand that this antigen derived from both coelomic and the Mullerian epithelium, and it expresses the 80% of the epithelial ovarian cancer, which are very common. It is unreliable for the mucinous clear cell and mixed Mullerian tumors. So it is not it is not very conclusive for everything, but in the majority of the cases, it gives the that the origin from where it can be and the potential for the malignancy. So it is one of the important tests. It is elevated in 90% of advanced stage ovarian cancer, but elevated in only 50% of clinically detectable stage 1 ovarian cancer. So a very high CA-125 gives you a definite impression in your mind that this patient can be can have the malignancy. But the borderline or the lower CA-125 do not keep you that this patient cannot have malignancy. So negative predictive value is not that good. Benign elevation include endometriosis, adenomyosis, pelvic inflammatory disease, liver disease, pancreatitis, and diverticulitis. And especially in the younger age, in comparison to the older age, the confirmation by CA-125 borderline or the lower levels and its association with the malignancies are not that good in comparison to it seems in the older age group. So that's why there are multimodal tests like RMI, ROMA, OVA1, which gives us the better idea to identify that whether this patient is benign or malignant. So RMI or ROMA score with the ultrasound score and menopausal score and CA-125 level, we can see and calculate this score. ACOG says that in the premenopausal patient, if the elevated CA-125 levels are more than 200 unit per ml, or if there is presence of ascites, or if there is evidence of abdominal or distant metastasis, or the family history of breast or ovarian cancer in a first degree relative is there, so one should suspect a high chance of malignancy, and these patients to refer to the person who can deal with them better. That means the gyne-onco referral is important here. In the postmenopausal condition, the level of CA-125 cutoff is different. The elevated CA-125 level more than 35 unit per ml is important in postmenopausal, which can be there can be rise of the CA-125 in the premenopausal patient because of so many things, but not in the postmenopausal patients. So this point I want to highlight more and more. The chances of ascites, nodular or fixed pelvic mass, evidence of abdominal or distant metastasis, the family history of breast and ovarian cancer in a first degree. These all things are the points where we should give them a gyne-onco referral. Coming to the second case, the patient present to emergency room with sudden onset of severe focal right lower quadrant pain following sexual intercourse. So here condition is little different. A young patient, pain, right lower quadrant pain following sexual intercourse. The vital signs are all right, respiration is little high. The additional information is again the SCG level are negative, hemoglobin average, Cullen sign negative. Ultrasound is suggesting a 5 centimeter ovarian cyst with a fine reticular pattern and small amount of free fluid. So we have seen that what this fine reticular pattern can be because of the hemorrhage. So first, again in this condition, we have to look for various things. What was the day of the cycle of that particular patient? Whether it is a normal ovulatory pain, mid-cycle, middle smudge pain, or it is the second half of the cycle. So can it be the corpus luteum cyst, or it can be anything else? So the correlation, clinical correlation with the dating of the according to the cycle is also important. We have to identify whether it is a physiological cyst like a follicular cyst, or the ovulatory pain, or the corpus luteum cyst. So follicle develops to maturity and releases the ovum, followed by formation of corpus luteum. Follicular cyst develops when follicle fails to release ovum. These all conditions can present with the pain sometime. Corpus luteal cyst occurs when corpus luteal fail to involute, and sometimes it can have the rupture also, it can have the twist also, and sometimes it may becomes the hemorrhagic. The management advised is usually expectant if the physiological cyst is there. The observation, but sometimes observation with admission is important. Emergent surgical evaluation if torsion occurs, or hemoperitoneum with hemodynamic instability. These patients may require inpatient observation if no hemodynamic instability, but large amount of pelvic fluid on the ultrasound. So those conditions where the hemodynamic instability is there, definitely they have to be admitted. But those patients who have the pelvic fluid not currently hemodynamically unstable, they also need a close observation. The ultrasound characteristics of simple cyst, 3 pictures are there. One is the sonolucent simple cyst that can be taken care of. Just rule out the torsion. The second cyst is corpus luteum cyst, which is a thickened walled circumferential color Doppler flow will be there. The small central lucency containing some echoes of the hemorrhage can be there. And third one is the hemorrhagic cyst with the fine network of the thin linear curvilinear echoes, sometimes called a fishnet or the reticular pattern. So these can be kept under observation and patient can be reassured. Another case present to clinic for follow-up of an chronic pelvic pain, dyspareunia, and transvaginal ultrasound suggested the 5 centimeter ovarian cyst. The patient is just presenting with the chronic pelvic pain and dyspareunia, and vital signs are stable. The bimanual examination with left is suggesting a not very large but a palpable left adnexal mass. So these cases are usually consistent with the endometriomas if they are having classical characteristics of classical characteristic of endometrioma. So those can be identified that no internal Doppler flow will be there. The echogenic foci will remain inside the collection, and hematogenous or hypoechoic area can be seen. There are low echo level and ground glass appearance. The management, if they are very symptomatic, the surgical removal. If they are not very symptomatic, then observation can be done. The fourth case is patient present to emergency room with right lower quadrant pain. So all are coming with a lower right quadrant pain, but they are having the different kind of the masses and different management. This patient present with the vaginal bleeding. The vital sign is stable. Abdominal examination show diffuse pelvic tenderness. The pelvic exam show trace blood in the upper vagina with no active bleeding. Additional information you got: HCG 2000, hemoglobin 11. Adnexal mass with the ultrasound is suggesting adnexal mass with the concentric echogenic rim of tissue surrounding a hypoechoic center. So along with that, a 2 to 3 centimeter ovarian cyst with thickened wall is also present. There is no intrauterine pregnancy, and stress-free fluid is there. I can even add that in the current era of the fertility treatment, one patient can even have the intrauterine pregnancy and along with such kind of condition. And I have seen one patient 3-4 patients who had intrauterine as well as the extrauterine pregnancy at the various sites. And I have also seen the multiple pregnancy in a single tube and no intrauterine pregnancy. So the different kind of presentations can be there, and all of them were presented as the adnexal mass. So identify them. This is supposed to be an ectopic pregnancy, and the management according to the ectopic pregnancy condition, whether it is stable or acute or chronic, whatever. So that is a different thing to talk about. So it should be managed on that particular line. And coming to the CA 125 predictive abilities, which I was continuously talking again and again, that in premenopausal women, the sensitivity remains 50 to 74%. Specificity remains very low to very high, 26 to 92%. And positive predictive value also have a very large range of 5 to 64%. So we got confused ki tabhi kya karna hai. And most in postmenopausal women, the sensitivity, specificity, PPV, everything increases very sharply when we talk about the CA 125. So serial assessment increase the sensitivity and preclinical ovarian cancer detection. So apart from CA 125, go for the IOTA, go for the ORADs, go for the other modalities and the clinical judgment, and then you have to decide about that. OVA1 is not for all the patients, but it includes more biomarkers, like apart from CA 125, beta-2 microglobulin, transferrin, transthyretin, and apolipo A1 are involved in this, and there is a particular algorithm to render a score from 0 to 10. So in a premenopausal patient, if this score is more than 5, then these patients are high risk, and then you evaluate according to that particular area. And in postmenopausal patient, this cutoff level is different. It is 4.4, and then you consider them as the high risk patient. Negative predictive value is very good of OVA1. And when you add OVA1 to imaging, further chances of clarity in mind increases. The ROMA, for the ROMA, I will say the algorithm that combines CA 125 with HE4 in premenopausal and postmenopausal women. It classifies tumor as high or low risk. In the postmenopausal women, again, the sensitivity, specificity. Sensitivity is good. Specificity is the same in the postmenopausal as well as in the premenopausal women for the ROMA. So the negative predictive value is very good, but the positive predictive value is not very good. For the morphological Kancke diagnosis, we go, it is done with the ovarian volume, and one can assess the ovarian tumor volume in the premenopausal women if it is less than 10 ml, and postmenopausal it is considered as the in less than 10 ml, if it is in the postmenopausal women, it is considered as a normal, and in the premenopausal it is 20 ml or more. So it can also be applied. There are the pictures given for the morphological index, and according to those pictures we can classify these all according to the sonography picture, and then we can identify whether this patient is a high risk or a low risk case. Learner's criteria are given, and there are 4 points to taken care on the ultrasonography imaging. That is the ball structure, shadowing, septa, and echogenicity. And for the each, there are various points given from 0 to 3. Not all the columns are whether there is always a 0, 1, 2, 3 will remain there. Some features are having 0, 1, 2, 3. Some features are only having 0 and 3. Value of overall 3 considered as the malignant potential. So for learner's criteria, in this picture is being shown like a simple small cyst is there, 4 centimeters cyst is there. So because it is cystic, unilocular size is less than 5 centimeters, so it will considered as low risk because the count is less than 3. For the multiloculated cyst, because the septa are there, that's why it will come under the intermediate risk. And where the solid component is also there, septations is also there, marked vascularity is also there, size is also large. So this patient will come in the high risk group. So this Lerner criteria makes the diagnosis simplified for the identifying whether it is benign or the malignant one. Iota predictive abilities we have already seen. The ability to achieve a high negative predictive value with the adding of the OVA1 imaging results can be done, and then we can have the further high confirmation regarding the malignancy or regarding the benignity of any tumor. Consider gynae-onco consultation, consider laparoscopy, laparotomy for any postmenopausal patient who has the CA125 2 times than the normal, and ultrasonography with suspicious malignant features are there. Perimenopausal patient with markedly elevated CA125 with worrisome USG, again we should consult it for the onco consultation and consider for the surgery. Pre or postmenopausal status with increased risk noted for formal assessment by any of the index, RMI, IOTA, ROMA, OVA, any should be considered for the consultation with the gynae-onco and manage accordingly. So thank you so much once again, Dr. Monica, for involving me for this webinar on a very complex topic. And as Meera madam said, that ovarian tumors, na tum jano, na hum jano. With the help of so many indexes, this is definitely now being better and clearer in comparison to earlier. Still, the ovarian tumors are not very simplified. They always give us some or other sudden things in front of us, and then we think that what has been left. So it is ongoing journey for understanding the ovarian masses.
Thank you so much, Dr. Jyoti. I think this was a very befitting web lecture after IOTA methodology, which you systematically have touched every point in clinical practice, the theoretical points, the practical points, the ultrasound points. And I'm sure all of this is going to add up to the panel we have in store for our panelists now. So thank you so much for summarizing the vast topic so comprehensively as well as compactly, and finishing on time so that we can discuss whatever you have spoken in the panel. Thank you so much, Dr. Jyoti, for joining.
Thank you so much, Monica madam, once again for giving the opportunity.
Thank you. So Purva, I think we are on the last leg of our webinar, and this is the panel discussion we are starting. And though a few of the panelists have not joined because of there's some busy engagement somewhere, but still we have quite a lot to make this engaging and interesting.
So moving towards our interesting panel discussion, that is gray zones in ovarian masses, what would you do? To moderate the panel, we have our very own Dr. Girija Wagh madam. Madam is presently past vice president of FOXI. She is professor and head of the department at Bharati Vidyapeeth Medical College, Pune. She is senior consultant at Cloud9 and Apollo Hospital, Pune, and she is a faculty professor at OGASH International Experts General Coordinator. She was past chairman of Medical Disorders in Pregnancy Committee, FOXI, vice president of Indian Chapter Guestosis, ex-member of Governing Council ICOG. She was joint national secretary of FOXI and was assistant coordinator National Eclampsia Registry. Also, she is a member of Central Supervisory Board of PCPNDT and National Mentor for Lux, NPO QCM, Ministry of Health and Family Welfare, Government of India, and also recipient of Anandi Bai Joshi Award for Excellence in Medical Services. We welcome you, ma'am.
Before we start the panel, I would give my personal thanks to Girja ma'am that out of a very, very super busy schedule, and I invited her when she was traveling. Madam has said yes, and she is yet again in Synergy program to brighten and lighten things up for all the panelists. Thank you, Girja ma'am.
Thanks a ton for appreciating. Thank you so much. I think we should we should introduce all the panelists first.
Yeah, madam, we'll just do a one-line introduction for everyone.
Yeah, no problem.
We start with Dr. Archana Singh, and we will only introduce the panelists who are present. Purva?
Yeah, please tell me that. That's important.
So Archana has not joined till now. Next, we have Debraj Mondal, who is very much with us. So we can see him in the group, and he is working as hi Debraj. He's
Hello,
working.
ma'am. I'm there.
Hi, consultant OBGYN, laparoscopic surgeon and fetal medicine consultant at Health World Hospital, Durgapur, West Bengal, and currently the secretary of Durgapur Obs-Gynae Society.
Okay.
Next, we have Dr. Dipali Shukla has extended apologies. Next, Manisha Shinde has not joined, but she will be joining shortly. She is a practicing OBGY at Akluj, and she's also the secretary of Akluj OBGY Society. Monica Gupta has extended apologies. Namita Agrawal, is she there?
Good evening, ma'am. Yes, I am there.
Hi, Namita. So
Hello,
welcome.
ma'am.
Dr. Namita Agrawal is from Hapur. She's she's vice president of Hapur Obs-Gynae Society. Has been the previous secretary and the scientific secretary. Her areas of interest are infertility, gynec, ultrasound. Welcome, Namita.
Thank you, ma'am.
We don't have Pratik Baman at present. He's in OT. We'll wait for him. And we have Rajshri Purbe from Darbhanga. Are you there, Dr. Rajshri? Okay, we have the president and secretary of Darbhanga Obstetrics Gynae Society with us. Rajshri Purbe is the secretary, and Dr. Kumudini Jha is the president. She'll be joining. Next, Dr. Ritu is not joining. Dr. Shikha Jain is also extended apologies. She's not well. And Dr. Shilpa will be joining. She's in OT right now. She's joining in 5 minutes. She is a very skilled laparoscopic surgeon, infertility specialist working in the city of Bhopal. She has been. Hi, Shilpa.
Hi,
Welcome. So, Girja ma'am, the panel is all yours to conduct. And last but not least, my great friend Kumudini Jha from Darbhanga, president of Darbhanga OBGY Society, a very keen academician, attends all our webinars, and welcome, Kumudini.
Okay, thank you. So we have Dr. Debraj, Manisha, Namita, Dr. Pratik, Rajashri, Kumudini, and Shilpa.
Yes, ma'am.
Is that right?
Yes, ma'am.
Okay. So I must at the outset first thank Dr. Monica for giving us this wonderful opportunity. The reason being, it's very important that we are all updated to what's happening in the ovarian cancer scenario. I just remember while I was discussing with one of my co-professors in the department, he said, no, madam, ovaries are very dangerous. And it's so very true because so many times we are unable to predict, and such a wonderful design of the webinar. Monica, congratulations for getting us such wonderful speakers also. I've been listening to their talks and that was so very nice. So gray zones in ovarian masses, what would you do is the panel that we have to discuss today. And I'm extremely happy to have all these eminent panelists. Some of them have not been able to be there, but I can see that there is Debraj, there is Manisha. I don't know whether Manisha is joined or not. Dr. Namita, Dr. Pratik, Rajeshri, Kumudini Madam, and Shilpa Dulani. So let's try to address these issues as much as we can. We had wonderful, informative lectures. Now we have to put all that information into some sort of an understanding in our clinical context. So we all know that it is a spectrum from benign cysts to aggressive malignancies, and that is what ovarian masses is all about. And then there are a lot of gray zones which arise when imaging and tumor markers conflict, when the clinical features don't align with investigations, and the patient expectations differ from medical judgment. So the key dilemmas are,
operative versus whether observe, balancing the intervention with caution, refer versus manage locally, defining thresholds for oncology input, fertility versus safety, preserving the reproductive potential without compromising oncologic outcomes, and communication versus anxiety, explaining uncertainty with clarity and compassion. So aim of this panel is to share these diverse experiences across practice settings, decode the diagnostic and management dilemmas, and build consensus on patient-centered pathways. And that with that purpose, we are going to have this particular dialogue through collective wisdom from uncertainty to clarity. And that is what we look at through these few minutes that we are going to spend together here on the screen. So this panel has been divided into various sections. The first section is the diagnostic dilemmas. So we have a 30-year-old woman who has a 5 centimeter complex cyst with low-level ECOS and mildly raised CA-125. Imaging suggests endometrioma, but symptoms are atypical. Now, this question would go to Dr. Debraj. What would you do for this? Would you observe, operate, or investigate further? And what would guide your decision? Remember, 30-year-old woman with a 5 centimeter complex cyst with a borderline, very minimally raised CA-125.
I would request the panel to please put on your videos so that madam can interact with all of you. If possible, please put on your videos.
Okay. Ma'am, I just first of all, she's a 30-year female with a 5 centimeter cyst, which I see from this video, and the CA-125 is mildly raised. So my first suspicion would be that this might be a case of endometrioma. So first of all, I would like to have a little bit of history from that, whether she has any family history of ovarian cancer or not, whether it's a recurrent disease or not, whether she has similar history in the past or not, and whether there is any history of any ovarian cyst operation in the past for this patient or not. All these things first I will say. And then I will have some further investigation because I have only done an ultrasound. So I want an further imaging like an CT scan for this patient to see whether there is any solid areas or not, or whether there is a lymph nodes or not. And also I would like to have some more informative blood tests, like only CA-125. I think I would go for a Roma index or IOTA for this patient.
Yeah, I think IOTA we can agree, but whenever it's a hemorrhagic cyst, we have all agreed that IOTA sometimes will not be able to give you correct answers.
Yes,
and even endometrioma actually happens to be a really, really complexing cyst. And the only thing that we can get through this history, what we have got is that there is a 5 centimeter cyst. So ultrasound features in an IOTA, what are you considering looking at?
First of all, I would.
Will we give this endometrioma all patients, then we'll do CT scan? Is that the reason why we should? It's just a complex cyst. So do we mean that we will do CT for all patients?
No, ma'am, actually, we don't need CT scan for all patients. First of all, actually, we should look for the features like whether there is a septation or not, how much is the length, thickness of the septation, whether any solid areas are there or not, laterally there or not, whether there is a free fluid is there or not. So these things we can also have a look from ultrasound also. Not necessarily that we will do CT scan in all cases, but sometimes we might need CT scan help if the USG report is not that confirmative.
Yeah. So when we are not happy with the IOTA, I agree to you that we may consider doing a CT or an MRI. And we should use and get into the habit of using the typical ORADS kind of a classification, because I'm just going to take you through one case which I've been recently coming across in the last 2 days. जैसे मोनिका ने कुछ बोला तो immediately such cases started coming to me. So therefore, after this panel, and we'll try to share some of them. So yes, I agree to you that we have to carefully do the sonographic evaluation. It's always better to have a transvaginal evaluation, but sometimes we do not have women at the age of 30, probably she's unmarried and is not very conducive to doing a transvaginal ultrasound. You may have to be taking recourse from ultrasonography report, or maybe abdominal one, or maybe consider doing an advanced screening, because you should be able to give the correct answer. And we are going to learn why we have to give that correct answer. Now coming to Dr. Manisha. Manisha, you have joined? Manisha? No. Dr. Namita, Yes, I can see Dr.
Yes, ma'am.
Namita on the
Yes,
screen.
ma'am, I am there.
So we saw that this patient had mildly raised CA125. And hubby, we are seeing quite often that this CA125 comes moderately raised. When it doesn't come raised, then we are a little relieved. But always we really do not know whether to be relieved or not. So what is the role of CA125 in reproductive age women?
CA125 is raised in endometrioma, PID, or even in simple follicular cyst also, ma'am. So only if it is mildly raised, like normally less than 35 is the upper limit of normal. But if it is more than 35 but less than 200, it is non-specific, so nothing to worry about. We can wait. If there are no other atypical features, like you said, like free fluid or septation or solid nodule, if it is a simple cyst or it has a fine reticular pattern only, then we can treat expectantly and we can observe the patient.
Absolutely, because nowadays
Because if we panic, the patient panics also, you know.
Yeah.
And if she is 30-year age group, it is very common for the CA125 to rise.
Yeah.
So we can nothing of concern.
Absolutely.
We have to
So
reassure the patient. Yes.
we'll not only reassure, we'll tell her that let's look at it again in a different context.
Yeah, we can
Just hold
get
on
it
a minute.
repeated. Yes, ma'am.
Yes. So premenopausal benign appearing cyst less than 5 centimeter can be monitored via ultrasound at 6 to 12 weeks interval, particularly if symptoms are mild. And serial monitoring would be what would be suggested. And as Dr. Debraj said, that MRI or maybe a repeat scan may be considered. And here it's always better, as he said correctly, that we have to look at various features properly. And it's always better to use the structured ORADS or an IOTA classification. And then when would be a surgical consideration? Will there be any surgical consideration? Dr. Pratik is there? Dr. Pratik, can I have you on the screen? Dr. Pratik is not there. Dr. Rajeshri? Is Dr. Rajeshri there? Dr. Kumudini, madam?
Yes.
Yeah, so can we have this question for you, that when would you consider a surgical approach to this particular mass?
Now, when this patient, she is premenopausal and with less than 5 centimeters. So if you are thinking that there could be, because of the, say, there is an ORADS classification and you get it, that there is a borderline tumor and you're not sure whether it is malignant or not, then we should, for the staging, we can do laparotomy. Generally, now people are using the minimum invasive surgery also. But there is always a chance that if it is a malignant one, there'll be upstaging. So it is better to do a laparotomy and then take the fluid from the cytic fluid, do a cytology, and you can classify whether it is a borderline. And if the patient is young, we can. If the patient is young and she needs to preserve her ovaries, or say she's it is a fertility sparing surgery, then we can advise her accordingly. And if supposing it turns out to be malignant, then also we have options to offer them, like freezing her ova or the cortex, and then you can give the chemotherapy or radiation.
Absolutely. So we will not quickly jump onto her maybe for a surgical intervention. We will just evaluate, see whether it's growing, whether regressing. I have recently had a patient who came to me in a perimenopausal age group, not perimenopausal, premenopausal. She was just around 34 years of age. And she had this pain and endometrioma, everything diagnosed. And then I said, let's wait because you're anemic. And in case if you are planning a surgery, but let's reevaluate you after 6 weeks. And meanwhile, anemia correction, lifestyle modification, everything happened. After 6 weeks, we found that there was absolutely this cyst had shrunk. It was an hemorrhagic cyst. So many times it's always better to give them some time. And of course, we have to do risk assessment and then consider these kind of a thing. So in this patient, we are seeing that the size is 5 centimeter. It was a complex cyst. Complexity definitely raises concern, as Dr. Debraj said. Mildly elevated CA125 is non-specific, as our Dr. Namita said so. And symptoms symptoms are atypical if mild, non-progressive, initial observation is acceptable, severe or persistent. And as we can see that Madam Kumudini has said that, yes, we'll wait and watch, and if necessary, in this context, with proper precautions, with fertility conservation, preservation, we'll consider a surgical approach. So the recommended plan would be watchful waiting with structured reevaluation and refer for surgical intervention if any of these things, as Madam said, occur, that it is persistent, there are consistent features and the symptoms of the patient worsen. So therefore, we would look at this particular evidence-based summary where it's better to be a little expectant in your management, look at all the risks and then make your plans. And then all this decision would be depending on whatever corroborative evidence that we have gathered through various findings. Now, I had mentioned on the group that I am operating, and this was the case I operated today. You can see that this patient had actually come for infertility treatment, and we did a baseline scan, completely asymptomatic. Her CA125 level, you can say, is just 19. But there is a mass, and which was considerable in size on the sonography. The radiologist said it's 6 to 7 centimeters, and it is complex. And then we did the iota. It was benign. It didn't have any malignant features. So we decided to do a laparoscopy. And what you can see here, that this is an absolutely healthy looking ovary, and it is attached to it on the surface with a very, very friable pedicle. And then we drained this particular cyst in a bag. There was some murky fluid which came out of it, and we have sent the cyst for histopathological examination. So what was the reason? Wouldn't it have regressed? Now, I sometimes feel, and Kumudini madam, you can correct me, that CA125 levels, when they are not active, that also means that if you're planning, let's say it's an endometriotic cyst, and you feel that I'll give her some, we typically give OC pills, or we give them Dynogest, or we give them Endogolix. We feel that it will help in shrinking such cysts. But if the CA125 is not present significantly, then I feel that they won't even respond to these treatments. And as you could see here, this wasn't sonographically amenably evaluated. The patient was not very happy to do this, but I said, see, you're planning to have a baby. And if this particular mass is coming in the way of a tubo-ovarian relationship, only endoscopy can tell us. And that's how we landed up doing this case today. It went well, and hoping to get a benign report on a histopathological examination. So I was talking to you about this particular patient, and what Debraj has said, I would agree. What Kumudini madam has said also, I would agree that we have to be sure what are we doing now. Because I would like to tell you one very sad story. This particular patient is my student. Long time back, she is now 30 in one of the states of India. And she very frantically sent me her pictures and tests. And she said, nobody is able to give me an answer about this. And she has undergone a sonography, and you can see that there are a lot of projections that are seen in the cyst. This is a cyst which is seen on the sonography. Iota has been done, and it is showing 40.6% possibility of a malignancy, because there are features, and these have been very specifically. So she was not able to make a decision. There was nobody able to guide her. So we had our own student was close by who's doing radiology. I told her, please go to her so she'll guide you correctly. And you can see that there is a simple rules have been followed. Stepwise evaluation of this tumor has been done. And then you can see that there are at least 3 papillary projections which are there present in this patient, and which talk and point towards a malignancy. Now, if you are having such a thing, as Dr. Debraj said, background, she's a young child, she's not yet married, and then if you're making a diagnosis of a malignancy, then it's always better to have an adjunctive evaluation done. Likewise, she was subjected to an MRI, and you can see that it looks like a very murky picture. And this is how you are seeing this, the left adnexal cyst seen laterally, and this is seen transversely. They have done a contrast, and you can see that there are a lot of other spreads, even to, it's been spreading to the fallopian tube. And the ORADs for this has come as 4. So it is an intermediate risk malignancy. Now, she has undergone a laparoscopic cystectomy 2 years back and doesn't have a histopathological report. Now, this person is a doctor herself. And you can see that we cannot get so casual about just the patient being young or just looking at the benign features. We have to definitely look at various other things. Now let's come to a postmenopausal woman. And I hope Dr. Shilpa is there. Dr. Shilpa, yes, I can see you. So if in the postmenopausal women with simple cysts less than 5 centimeters and normal markers, do you follow IOTA, RMI, or the clinical instinct? And which scoring systems do you trust most in your practice?
Ma'am, in my practice, I prefer IOTA. Doing IOTA, I have a printed paper on near my ultrasound machine, in which we just go on checking and ticking all the points, including the size, the vascularity, the papillary projections, everything, and then we take out the risk. In postmenopausal women, we have to be extra careful, and we have to keep a close follow-up in these patients, and we have to do CA-125 even if the cyst size is less than 5 centimeter. So we keep calling them every month, and not as for young patients, we call them a little earlier also.
Yes, can you tell me, Shilpa? There's a patient who is making a lot of noise around here, so I was just attending to her because it's my OPD going on. Yeah.
Ma'am, in postmenopausal women, we have to be even more cautious. We have to do IOTA and we have to do CA-125. We have to do a monthly follow-up, and even cyst less than 3 centimeter, okay, we are still okay. But between 3 to 5 also, we have to be very careful. We have to do CA-125. We have to keep calling the patient. We have to monitor her closely.
Correct.
Then we can decide what to do next.
Absolutely. So there are certain guidelines which are talking about, there's an RCOG Green Top guideline, which is talking of transvaginal ultrasound plus serum CA-125 and calculate the RMI. They follow an RMI a lot. And normal levels do not rule out malignancy is very important, because if you remember, I showed you the CT and the MRI scan of the patient. And that CT MRI scan has shown that she had normal, she looked like intermediate malignancy, and all her tumor markers have come normal in that particular patient. So we have to be careful even if the tumor markers come normal. And then, of course, size-wise stratification is what has been presented by certain groups, wherein they say that if it is less than 3 centimeters, no follow-up required, or 3 to 5 centimeters, then looking at the CA-125. So taking everything into account, the primary risk, we have to take our actions. And that was a very wonderful answer that you gave, Shilpa.
Ma'am, any peritoneal disease, maybe it is endometriosis, it is endometrioma, anything that is invading the peritoneum will cause an increase in CA-125. So the borderline increase is just because of the encroachment in the peritoneum.
So yeah, so we would like to look at it now. There are certain modifications which have been done in the IOTA simple rules that we have to see. We saw one report. Now this IOTA simple rules and LR2 is something which has become now adjuncted to this particular thing. Would you want to comment anything on that? LR2, the second, what have they done is they have also taken into account not only the features, but also the CA-125 together.
Yes.
And they would talk about all these things in context. And as you said, that even in simple thing like gastroenteritis, sometimes CA-125 can raise.
Yes.
And therefore, we have to be looking at this a little consciously. So this LR2 is a logistic regression model, which was developed by the IOTA, and it was derived from a large multicentral data set of over 700 women across Europe who required surgery for an adnexal mass. So whenever we have a patient coming with cysts and everything, we should be able to tell them the correct answers. And these are the typical LR2 6 predictors, as you can see: the patient's age, presence of ascites, papillary projections, maximum diameter of the largest solid component. This is getting a lot of traction and importance nowadays. Irregular internal cyst wall and presence of acoustic shadows. And these variables will help us in making and understanding what we are going to look at. What has happened is, when we look at this categorically, we can see that there is definitely an increase in the sensitivity to 90% and specificity to 89%, comparable to just looking at only the IOTA simple rules. So if you try to take everything together, that would be better. And how you would use it in the practice? In a similar way, as you mentioned, that I would like to evaluate this patient, follow up her, and then decide to take a call. And this is therefore a well-validated quantitative tool which we can use. And it is offering a numerical probability of malignancy and aiding in evidence-based decision making. So this is how the LR2 model calculation happens. This is a very complex formula, but most of these Voluson machines which we have, they have already fed it inside. And these are given credentials. And you can see an example here of a 55-year-old woman who has ascites, papillary projections, solid component of 30 mm, irregular walls, acoustic shadows are not there, but the calculated malignancy risk therefore has come 78.6%. And therefore, it gives us an objective analysis so that we can guide our patients properly. Do you want to speak anybody in the group on RMI4? Are you aware that there is an evaluation of RMI4 now? Anybody would want to say something? Debaraj?
That is the, yes.
Yeah, Kumudini madam, yes, please.
Yeah, this is a risk assessment model, and you take into consideration the ultrasonographic features, the menopausal status, whether she is premenopausal or postmenopausal, and also the CA125 levels. And then the tumor size is also taken into account. And then you see what is the score. If it is more than 200, then the patient is considered as a case of malignancy. Yes, ma'am.
Somebody else is talking, not me. Yeah.
Oh, so according to the RMI score, we can consider Yes, ma'am. Can I answer?
Yes, you can answer. Actually, I'm not talking. Somebody else is talking. Answer, madam.
So it is the value that is found on assessing the ultrasonographic value, the score, the menopausal status, and the CA125. So you're given a score of 0, 1, and 2 according to the features of the ultrasonographic findings. That is whether it is a multilocular cyst, there are solid areas, there are bilateral lesions, ascites, and the presence of metastasis or not. Now, according to the menopausal status, if she's premenopausal, you give her a score of 1, and in postmenopausal, she's given a state of a score of 3. And according to the CA125 levels, the absolute serum values, you give it whether it is more than 35 or less than 35. And the tumor size is also taken into account, whether it is more than 7 centimeters or it is less than that. And you assess whether it is more than 200 or not. If it is more than 200, the totaling, then it is a case of malignancy.
कोई संवाददाता जो है वो बहुत नहीं लगता है कभी 1:35 में कॉल आया.
I'm so very sorry because there was some sort of a patient who was troubled about everything. Yes. So as you rightly said, Kumudini madam, that we have now to the RMI attached tumor size factor as a risk stratification, and that has added to its efficacy, as you can see here. And these are studies which are not only global, but also there's an Indian study of 117 patients, wherein in the 2020 study, the RMI4 exhibited sensitivity of 66.7%. Among epithelial ovarian cancer, it had high diagnostic accuracy. While in the Indian retrospective study,
Madam, your
line versus malignant lesions.
Yeah.
Yeah. So this can be applied in our clinical context, and this can help us in taking reference decisions and interventional decisions as us, because it's always better that whenever you're suspecting a cancer and we are sure about it, It's always better to take the oncological team on board rather than we dealing with these problems. So that is very important. And this is how the calculation is done. Now let's look at this particular woman with 2 or more suspicious ultrasound features. She scores 3 and M is equal to 3. Tumor size is 8 centimeters. S is equal to 2. CA-12500 in the actuals. And then she has a high score of 450, as you can see. So this M comes with the menopausal age, as we are seeing, and then this would warrant a reference. So when MRI suggests borderline features, but ultrasound is reassuring, how do you reconcile the findings? Is my question to Debraj, if he's there, or Dr. Whoever can take the question, of course, who is on the screen, I don't know.
Yes, ma'am.
Ah.
Can you please repeat, ma'am, question?
So when MRI suggests borderline features, but ultrasound is reassuring, how do you reconcile the findings? Do you repeat imaging, rely on one modality, or proceed surgically?
Ma'am, first of all, you have to see whether it is like TVS or abdominal scan. We only TVS scan we can actually rely upon, but the abdominal scans I think are not good enough for evaluation in ovarian tumor. First of all, so in unmarried women and all, obviously, if it is not a TVS, then we have to discard that, or we have to think for an MRI better. Also in postmenopausal women also, ma'am, I think MRI will be a better modality as compared to the ultrasound. In this patient, we are seeing that the MRI suggests a problem, but the ultrasound is completely normal. So in this patient, obviously, I will take it as serious concern because MRI is much more sensitive than the ultrasound. So I would go for further evaluation of this patient because I have to find out whether there is a malignancy or not in this patient.
Absolutely. So we have to understand that where we are going to advise and where we are going to stop this patient from understanding. So ultrasound again has to be done systematically. So if you remember, I showed you that student of mine, her scans, which I have just received today, she was being sent from one doctor to another, one facility to another, not knowing anything. And all her previous scans were absolutely done arbitrarily. I know that there are many experienced doctors who have this gut feeling that yes, this looks normal. But today is an era where we need to categorize it correctly so that we are able to quantify the treatment also that we are giving, especially in young women. We have to be very, very carefully. So ultrasound, ORADs also can be done and IOTA can be done. And MRI, as Dr. Debraj said, serves as a problem-solving tool for intermediate or ambiguous ultrasound findings, demonstrates high accuracy to the tune of sensitivity 93% and specificity 91% for intermediate masses where we are in doubts. So when we are reconciling on such discordant findings, the dilemma, how do I make a diagnosis? Then you have to look at the scenario examples correctly, as we were looking at ORADS US23, ORADS MRI4, repeat imaging maybe after 6 to 12 weeks, multidisciplinary review, assess the clinical contents and consideration of surgical consideration with a biopsy. And as Dr. Kumudini was saying, that today we can also consider doing a laparoscopic staging diagnostic also, because then that helps us in being minimally invasive at the same time doing a proper tissue sampling. And it also requires cautious navigation. MRI showing borderline features, even with a benign ultrasound, warrants repeat imaging by multidisciplinary evaluation. And this would then align with the ORADS protocols correctly. Now, there is also ROMA, and which was wonderfully explained in our previous talk. How many of you perform ROMA for your patients? The ROMA score, where we use the HE4 and the CA-125 and the menopausal status. Anybody?
Ma'am, I actually prefer Roma over CA-125 because we have a routinely habit of like we evaluate this complex masses with a Roma index because I know what I learned that HE4 is much more sensitive than CA-125 because whenever there's a peritoneal disease involved and there are a lot of like patient is menstruating, even CA-125 can be raised and it can be like non-gynecological problems. It can be raised. So to make it more specific, I think HE4 gives us a very good edge over the CA-125. That's why apart from doing only CA-125, we prefer doing a Roma index. Though I'm not saying that always it should be done as a first line, but when you are getting a high CA-125 patient referred from outside, then the second investigation we do is Roma.
Yeah, so Roma now done in a proper algorithmic way, done at the same time, And if it is fed to there is a very complex formula which derives the score. It can definitely help in improving the sensitivity and the specificity, not the specificity, but the sensitivity. And therefore, it would be a right approach. And if Debraj, you are having so many cases, I would invite you to be part of the SDoc study of Foxy. You have my number in the group. You can just send me a WhatsApp. I'll enroll you, because we are trying to collate data of 1,000 women across the country, and where we are offering them CA 125 HE4 Roma at a very substantial cost. So you can participate. All of you are invited to be part of this study. Each one of you have to just contribute 5 cases from your region, and we'll give you the specifications. So yes, and what is the catch then, Debraj? You have been using Roma and HE4, and there is a catch in interpretation. Have you understood and realized or experienced such a catch in your patients?
Ma'am, catch means I didn't get the
You
question,
didn't
ma'am,
get the
please.
question, but I'll tell you the clue. Premenopausal, postmenopausal is a catch.
Okay, ma'am. Okay.
Isn't it? Now,
Yes,
how do
yes,
you
yes,
know that
definitely.
this woman has achieved menopause or not?
Only history,
Yeah, but history is not sufficient.
And
not
FSH
sufficient.
levels, FSH
FSH
Yeah,
level
so
has to
in
be
that
done.
place, now I will tell you, my own student, now she's become a big consultant. She came to me with this report. Roma had come high, and she doesn't know her periods have been coming on and are very less than 6 months back. We don't know whether she's premenopausal or menopausal. And the iota and the MRI were completely looking as normal, and it in fact looked like an endometrioma. So then what I did was I said, let's do your FSH levels. And as Dr. Kumudini madam said, the moment her FSH levels were done, she went into premenopausal category. And then we interpreted it came as low risk. Understood? So catch can be whether the menopausal status, because all of us will agree that it is a retrospective diagnosis. There is no way, and therefore that is how we will have to negotiate. And later on, we put her on Egolix, everything subsided, and I've been putting her under surveillance. And this has been the story of about 8 months back. Her 6-month scan and the serum markers all have shown normal study.
Ma'am, can I add one point
Yes,
here?
of course you must, yeah.
Ma'am, I have a patient. Actually, this patient is a follow-up case of mine. She came to me with a report of a Roma index of like she's like a 30-year lady, 1P1L1, and she has a previous normal delivery. And she presented to me with a Roma index report of 65, a high risk. And obviously, they were very worried that what happened, because the ultrasound report, there was no absolutely no cyst, nothing. I think there was a previously 6 months ago, there was some small cyst was there, and some doctor advised them a C125, which was raised, and they also advised a Roma index, which was also raised. She came to me with a report with the Roma index of 65, and I have repeated the report also from another lab, and also it came out of 59 or something. And I did the ultrasound. I have not found any cyst of this patient. So in these situations, whether Roma is absolutely like, what should I do in this patient? I given up Dynogest and I'm just following up, and the Roma index now after 6-month therapy, it is reduced to like 13 or something. But what are the chances? Like Roma can also be false in some patients. That's
Yeah,
why.
it can be false, but you know something, what all tools that we as gynecologists have is looking, and now because there is a lot of consensus in 2022, everybody has said that you need not put in a laparoscope always. You can do the IDA strategic classification based on ultrasound for adenomyosis and endometriosis. There can be peritoneal endometriosis, there can be interstitial endometriosis, which requires to be evaluated, which may throw up these levels. I have a patient who for 20 years I've been managing her endometriosis. She never had children. She took adopted a son, and absolutely irregular in treatments. Came with a full blown mass of endometrioma. Everything up the sky. CA125, HE4, you name it. And then it was going to be a very difficult surgery. We finally did a laparoscopy. She didn't respond to anything. And then those all the tissue analysis have come completely benign, no cancer there. It is just endometrioma, endometriosis, which was extensive. Fortunately, it was in the form of a cyst loculated, and she had a very bad adenomyosis. We removed the uterus as well, because now she's become 48. So what I'm trying to tell you is endometriosis is one of the most enigmatic diseases. But at the same time, as I told you about my co-professor saying, please be careful about the ovaries. They can behave in any which way. And today, a lot of peritoneal malignancies are coming up where our knowledges are very limited. We are really not knowing what they are. And therefore, it's smarter to keep them under surveillance. Don't let them go. Tell them that we want to look at you, what's happening. And then accordingly, we will have to take a call, because CA125 can be raised in so many other conditions as well. Breast cancers can be there. We really do not know. And maybe that would skew your Roma analysis as well.
Yes,
That was
ma'am.
what I
Thank you
was.
for this, for the analysis.
So
Thank you,
let's come to the surgical judgment section now. We finished the diagnosis. A presumed dermoid turns out to be a solid vascular mass intraoperatively. Do you proceed with staging, call for frozen, or refer? What's your protocol? Yes, anybody would like to take this answer? Dr.
Yeah, we should do the assessment
Huh.
intraoperatively with a frozen section because it is solid. And if it turns out to be a malignant tumor, then we would definitely like to have an oncologist on board.
Yeah, that would be nice, but they wouldn't be available to us so easily. Anything else you would want to suggest? On
No,
table, if you are suspicious about a mass, what can be done best at that time?
remove the ovary.
Yeah,
If-
but inside, maybe take it inside a bag.
Yeah, in bag.
not-
Yes, we
yeah,
don't want to
it-
cause chemical peritonitis.
Yeah, not only chemical peritonitis, unfortunately,
And
with
spread of
non-small
the tumor.
cancer, yeah, we don't want to upstage it. So we have to be a little careful whenever we are having this kind of a thing. And so be ready that this would happen. Of course, your priori imaging nowadays should help you. Now, how do you decide between laparoscopy and laparotomy in borderline or suspicious masses? I know, Dr. Kumudini, you did mention about it at the outset, that whenever I have a suspicion, I'll rather go in for a laparotomy than a
Laparotomy,
laparoscopy,
right,
which
right.
you are absolutely right. And definitely infrastructure or team availability would influence our choice.
Yes, yes.
Anybody would like to add to this? Anybody? Now you are having a patient whom you are evaluating for something else, maybe infertility or fibroids, and you find that there is an incidental ovarian mass. What would you do? She's asymptomatic.
Go in for tumor markers.
Yeah, so we'll follow the same diagnostic protocol and then think of surgery, and we'll not jump. And even if you, now, for example, you are doing an infertility evaluation, if you find an ovarian mass, I think you have goofed up, because it's always better to do a sonography properly before you decide to take. I have stopped it. I've just stopped trusting on any ultrasounds done outside and sometimes done long time back. Patients will do a sonography, then she will sit, discuss at home, and then she'll take a decision and maybe come to you after 3 to 4 months. And that time you will say कि अभी ये already एक sonography करके आई है, इसको कितना बार-बार check करने के लिए भेजना. And in that nautanki, sometimes there may be nothing. So it's always better that you do a pre-operative proper evaluation of the masses, and that's going to be able to help us. So whenever we would pause and consider malignancy, and of course reserve a request for frozen section, it would offer us a 90% accuracy for benign versus malignant, though specificity for the borderline tumors is a little lower. And then based on the results, you will decide to take a call whether you're going to do a laparotomy or you're going to take a omental biopsy, or whether you are going to. So always be prepared that there can be unexpected surprises. The today's patient, which I showed you, I was thinking that it's going to be an endometriotic cyst in the ovary, ovarian endometrioma, but it turned out to be something else. So whenever we're talking of laparoscopy versus laparotomy decision in borderline or suspicious masses, for early epithelial ovarian cancers, laparoscopy offers similar overall progression-free survival compared to laparotomy without compromising outcomes. In the BOTS, tumors less than 10 centimeters, laparoscopy is safe with fewer complications and shorter hospital stays, and long-term recurrence rates are similar. In tumors more than 10 centimeters or high risk, example mucinous subtypes, increased risk of rupture with laparoscopy is known, and therefore it's always better to take them for laparotomy. This is what the current evidence is talking of. Of course, contextual factors like infrastructural skills, we would take into consideration patient factors like significant adhesions, large tumor size, risk of spillage, unclear margins would favor laparotomy. And always choose laparoscopy for masses under 10 centimeters better, and try to do it in a best resource possible. And maybe you can, if you're having a suspicion, you can call on board an oncologist already before you are trying to intervene into the patient. Now, incidental ovarian masses in unrelated evaluations, there is usually no interventions unless they exhibit concerning features, and this triage would be based on menopausal, premenopausal status, and the size and the complexity of the tumor and the CA125 associated. And as far as infertility is concerned, whenever we are trying to look at these complex masses, you cannot only think of endometrioma or infertility, you to also have that antenna swinging behind you. Is there going to be any possibility of a cancer? So it's always better to follow the ASRM fertility evaluation guideline, where it will say imaging incidentalomas, but elective surgery only if they are large, symptomatic, or largely damaging the ovarian reservoir fertility outcomes. Assess the complexity, monitor the simple small cyst, maybe with serial imaging. Surgically evaluate if they grow or become symptomatic, appear complex or solid, and have concerning tumor markers. And treat incidental masses contextually, monitor if small, simple, and asymptomatic. Intervene surgically only if risk increases or fertility could be compromised. So what would be your referral thresholds? Anybody would like to answer this? What are your red flags for immediate referral to a gynec oncosurgeon? Is it size, morphology, ascites, or something else?
First of all, ma'am, solid
Which-
areas are very, very important. If you are
Uh,
finding a solid area or like suspicious solid area, thick septations in those patients, I think better to take an oncology referral before opening.
Before opening. And what would you do in smaller towns? How do you manage when referral isn't immediately feasible? You may not have a cancer surgeon there.
In those patients, ma'am, actually we try to not to open the patient because once you open it, the staging is changed. So that's
Yeah.
why if you first evaluate the patient properly, if you're suspecting it can be a malignant or you are suspecting it to be malignant, it's better not to treat this patient, better not to do a surgery because it is difficult for the oncosurgeon to do a second time laparotomy also. So first time you can do a laparoscopy and see if it is inoperable or you think it is beyond your operation capabilities, you need an oncosurgeon, it's better to stop it there and refer the patient. Otherwise, initially you evaluate properly whether you are going in with a case like suspected malignancy or something. In those patients, if you are not an expert in oncosurgery, if you're not an expert in lymph node dissections and all, it's better to refer to a center where the oncosurgery facilities are available. So it is my personal opinion, ma'am.
Absolutely, I would agree to you because today is an era where I remember I have one patient who came from Hong Kong, and she said, I have a septate uterus and I'm planning to get a pregnancy. Planning to get married. Before marriage only, she's done her pre-fertility evaluation out there. And now she's saying that what are my chances of getting pregnant and all. And then I went into Hong Kong to a very senior doctor, and he said that I don't have an experience. Then she said, I consult with somebody. I said, nobody will take responsibility for you, my dear, because you are so anxious about it. And even if we do this, we are not able to give you that 100% guarantee of a result. So the today's era is take responsibility, which only you can, because anything can turn up. And as you very rightly said, that let's be on guard with all the red flags. So Dr. Kumudini, would you want to guide us with what will be these red flags which will warrant immediate referral to gynecologic oncology?
First, the age of the patient, postmenopausal status, the findings of the size on ultrasound, whether it is more than in postmenopausal patients, more than 5 centimeters, you can't wait. And what is the vascularity, whether there the presence of nodules or not, and whether they are vascular, and what is the size of the tumor. What is the thickness of the septum and whether it is multiloculated or not. And you calculate, do the CA125 and calculate the RMI. And if it is more than 200 and yes, the CA125 is HE4 should be done in all postmenopausal patients. And then if you find she's high risk, definitely shift her to a place, a tertiary center where oncology is available. And in those places, I think robotic surgery would be good if it is possible.
Absolutely. So we have to think about our resource limitations and understand this. So managing in resource limited settings where referral isn't feasible, we can consider at least doing a proper risk stratification primarily. That is in our hands, which we can do.
Right.
And then maybe doing telemedicine consultations or remote image reviewing, or then maybe conservative management, close surveillance, and then sending her to an appropriate place would be the right approach. And expedited transfer protocol when it's necessary. As we said, that if it's going to be a cancer, then we have to see that they go to the best place, and always remember that the primary option and the primary surgery and a primary intervention is going to give her the best chance of survival, if at all, rather than we doing hodgepodge things repeatedly. So the evidence says that AFFP guidelines underscore size more than 10 centimeters, solid components, and ascites as high-risk features. ACOG practice bulletin emphasizes on morphology, family history, menopausal status, and tumor markers, as you rightly said, Kumudini madam. And ORAS risk stratification recommends referral for category 4 or 5 lesions. And Frontiers in Medicine support using risk tools, RMI, IOTA, and image sharing to guide management in low resource settings. So the final recommendations would be refer immediately if any red flag features are there. In resource limited settings, use structured risk tools and document thoroughly and educate patients about the possibilities of what can happen. So now come to the fertility versus oncologic safety. In young women with borderline tumors, how do you balance fertility preservation with oncologic safety? I already showed you a young woman, 30 years old, that doctor whose reports I showed you in the beginning. Any recent cases that challenge your decision making? So I've showed you one. You can also share any of yours. And do you offer fertility sparing surgery in early stages of malignancy? And what's your threshold for risk?
Yes, we should. And the patients who are not aware of it, we should counsel them that these are the options that are available. And in unmarried patients also, you can have them. So depending on the diagnosis, if it is there and they have to go in for chemotherapy, now we have the dual stim also. You can stimulate the patient's ovaries and get the oocytes, freeze them. And because they may go upstage if you are going to delay because of the ovarian stimulation. So you can do a dual stim and save that, or the cortex of but the risk is that when you put it back again, there's a thought that it can develop into a secondary, again, carcinoma stage. So you can freeze the ova, and then later on when her chemotherapy, her radiotherapy is finished, then she can use those ova for IVF.
Absolutely. So we are seeing that very young girls, like I know a 22-year-old girl had to go in for oocyte freezing followed by all kinds of radiation and chemotherapy, but she did not have a cancer of the ovary. Cancer of the ovary, as you madam rightly said, is a totally different ball game because the tissue is going to really cause a problem once again, and we really don't know. One of the challenges we also have is the ovary and the peritoneum happen to have the same response.
Development.
Absolutely, because developmentally they are coming from the same origin, and therefore we really have this limited understanding, and only we can continue experiencing and sharing experiences as we are doing here because of Monica. So bots, yes, bots generally have an excellent prognosis and often present in younger patients at early stages, usually FIGO 1. And FSS, that is fertility sparing surgery, preserving the uterus and at least part of one ovary, is widely supported by recent guidelines for appropriate cases. And as you mentioned, we can do these kind of things. And recurrence after, like you saw that same patient of mine, but they didn't do a fertility surgery or anything, occurs in 10 to 30% of cases, depending on procedure type and tumor characteristics. Cystectomy has a higher recurrence rate and earlier relapse compared to unilateral salpingo-oophorectomy, that is 20%, though overall survival remains unaffected. And high-risk features such as micropapillary histology, bilateral tumors, and intraoperative rupture ascites significantly elevate recurrence risk. So let's look at fertility outcomes and assisted reproduction. IVF post fertility preserving delivers live birth rates similar to controls up to 60% and does not increase the recurrence of benign ovarian tumors of low potential as long as ovarian stimulation is delayed for more than 3 months post surgery, is what has been said. So let's look at a challenging case. A 19-year-old with stage 3 serous bot underwent FSS twice following early recurrence. Despite the recurrent disease, fertility preserving approaches were maintained, emphasizing the challenge of managing advanced stage bots conservatively. Early pregnancy post FSS was advised to minimize recurrence risks. So this is something which is too adventurous, and she's such a young girl and you would want to consider. But there are always going to be challenges, and I don't know what has been your approach, Kumudini madam. You have also been quite senior for a long time. I have always given patient a choice. Is it important to have babies or is it important to live life?
Only if she lives can she see a baby, so she can use surrogacy also.
Yeah, or maybe adopt one.
Yeah.
Yes, absolutely. So what about this fertility sparing surgery in early stage malignant cancer? So which stages would you consider this particular surgery, FSS?
Up to stage 2, maybe not beyond that.
Yeah, so stage 1A or stage 1A, C1, C2. And oncological outcomes and recurrence rates have been mentioned and have been studied. There's a recurrence of 3 to 33%, most commonly 8 to 15% in a cohort study. And overall survival, however, is excellent, 88 to 100%. And FSS recurrence was found 4.5% with 15-year survival, similar in both the groups. And all the guidelines emphasize tumor grade, stage, and histological subtype. And as you rightly said, less than stage 2, yes, you would consider maybe. And therefore, you would choose FSS very, very properly and wisely wherever it is going to be feasible to give her a possibility of no recurrence and a better fertility outcome. And that is what we have to decide. So if it's a BOT stage 1, then FSS indications oncological risk recurrence is 10 to 30%, no survival loss. Fertility strategy can be IVF after 3 or more months post-operative. Stage 1A, grade 1 to 2, FSS post-staging, recurrence 8 to 15%, survival 80 to 100%, multidisciplinary counseling. And stage 1C, low grade selective FSS, slightly higher recurrence, intensive surveillance is what is recommended. So it's very important that we look at the borderline tumors properly. Early stage malignancy, IVF can be safely pursued, and multidisciplinary approach is a must. Now, imaging versus tumor marker conflict. Now, sometimes you will have a benign looking mass with an elevated CA125. We've already discussed that. And we also discussed that CA125 can be elevated in so many other reasons which has been put up there. And as Dr. Debraj said, that transvaginal ultrasound remains the primary modality and you will have to look at it. So what would be your preference? What would you base on? You would like to look at CA125 or you would like to look at imaging? When there is a conflict, what would you do?
Both are required.
Okay.
And it's not only CA125, depends on what type of tumor. It could be LDH could be high in choriocarcinoma. It could be embryonal tumor in which AFP could be high. And of course, in postmenopausal, HE4 is a must.
Absolutely. So you will always like to take everything into context and not depend on any one of them or give them any kind of a priority. Sometimes, however, there can be some ambiguity where you may have to take recourse of doing a laparoscopy for looking for endometriosis, malignancy, or tuberculosis, because genital tuberculosis in our country is a very common condition and it can give rise to frozen pelvis. If we have time at the end, I'll share you one terrible occurrence of tuberculosis in my life. And in resource-limited settings, laparoscopy is both diagnostic and therapeutic, especially when imaging is unconclusive. CA125 biopsy access can be sought, and TB and endometriosis coexist or mimic a malignancy. So these can be brought about by probably doing a laparoscopy, and therefore, as Madam Kumudini said, we would like to take everything into context. Now, the last part of this particular panel discussion is the patient communication. You have a patient with a 7 centimeter multilocular cyst and normal CA125 is anxious and requests surgery despite benign features. What would you tell her? How do you balance patient anxiety with clinical judgment, and would you operate or counsel further? Yes, anybody would want to answer? Yes.
Counseling will be the first thing, no, obviously, because she doesn't have any particular features. It's a 7 centimeter mass. Though it's a like borderline 5 centimeter, below 5 centimeter, I would definitely go for counseling. But still, 7 centimeter mass looking benign, CA125 normal. In this patient, I would just follow up, or maybe I will give some medications like Dynagest or something, but I would not operate initially from the very beginning of this patient, because this is somewhere the patient counseling and communication is very important. We have to properly counsel the patient what are the risks of malignancy in this patient. Also, we have to take into account the patient relatives also and tell them what is the features and what is the prognosis of this. Because doing a surgery is not that, maybe it may be unrequired surgery, maybe the cyst will automatically dissolve. So that's why you have to counsel this, very important. So at least give us some time and follow up the patient. And the cyst is not improving or something, like cyst is showing any features of any malignancy or something, then obviously you have to go for surgery,
Yeah.
but not initially.
How could, yeah, yes, madam.
And to put her anxiety to rest, you can advise a higher modality of investigation like MRI to assure.
Yeah. So you would try to use everything possible to help come to a right diagnosis for your patient. Now, many times we have relatives who come and tell us, madam, the cancer hai, to please usko mat batana. Would you involve patients in decision making when the diagnosis is uncertain?
Yes. Patient, you have to involve, not the relatives.
Yeah, you can't keep them, you can't keep it hiding from her and then tell the relatives, no, and tell her that no, it's benign. Because I think when we are let's imagine that we are in the shoes of the patient, we would always want to know what's happening to us, right? We wouldn't want somebody to just protect us under the garb of falsitude.
Maybe, and you would be in a foul situation with the medical legal, because they may say you said it was benign and
Yeah.
to malignant.
Absolutely. So these gray zones can be taken care of by proper imaging. So balancing anxiety versus clinical judgment is very important. Your worry is completely understandable, should be our first statement. Explain all the features, offer structured follow-up, repeat imaging. And then if anxiety persists, despite reassurance, consider surgery only if risks are low and fertility can be preserved. And then if there is, without alarm, you can say it's like a weather forecast. Some clouds don't mean a storm. We are watching a movie frame by frame to see how the story unfolds. So we have to be using very simple language so that they understand that we are not taking them through some sort of an experiment. And frame options clearly. We can monitor safely or proceed with surgery. Each has its pros and cons. And maybe using decision aids or visual charts. And what matters most to you, certainty, fertility, or avoiding surgery, we have to negotiate each one of them and try to talk. So in conclusion, I would like to say that adnexal mass management, it's very important to have evidence-based decision-making, proper surgical judgment, bridging care in limited settings, fertility versus oncology, patient-centered communication. And that's how we would be able to probably negotiate this menace. And I would like to really thank the panelists for giving such wonderful insights and Dr. Monica for giving us this particular screen so that we could share our experiences. Thank you, Monica. I hope you have been able to do some justice to what task you have given us.
Madam, you have
More than justice.
101% justice. And Kumudini madam was a last minute entry because I was not getting enough panelists.
And she was a screensaver.
Thank you.
So I told, she said, Monica, I'm not prepared. Monica, you are prepared for everything, madam.
I'll tell you with my panel discussions, don't get stressed out. I usually write the answers on the screen and I always like to give some messages through that. It's not only, sort of viva or anything. We are all supposed to share our experiences. So
And
many
madam, one
things
thing I noticed about your panel, Girja ma'am, was you never said wrong to any answer.
Right.
Never, ma'am. That is like
Encouraging.
You encouraged to, you took out the right answer from every panelist.
It
So
was
I
a
think
wow
this-
panel, madam. It
Very
was
nice.
a wow panel.
Thank you so
So
much.
thank you so much, Girja ma'am. Thank you, Dr. Jyoti. And of course, thank you to
I must thank Monica because whenever I get invited for any kind of gynecological and cancer and all such kind of things, I love to take part because neither everybody thinks that I am only an high risk obstetrician. I do a lot of other things as well.
Madam,
So I love it.
Madam, you are a statement in gynecology. Absolutely, absolutely, ma'am. And thank you so much, everyone. Thank you, Aligarh and Gorakhpur and Meerut societies. Thank you so much, all the speakers, faculties, and panelists for being there for such a long time. We are nearly 3.5 hours since we started. So have a great weekend ahead. It's week ahead, not the week.
New beginning.
And thank you to Team Inters for the academic platform. Thank you, Vishal. And till next time in December, we'll select a nice topic and share with you all. Thank you, ma'am.
Anybody
Thank you so
interested
much.
in
Thank you,
being part
Dr.
of the
Monica.
ELDOC study of Foxy, please tell me. We'll enroll you.
Ma'am, this study on ovarian tumors?
Yes. Ovarian.
Ma'am, in fertility practice, we keep getting ovarian masses, but it's not like hardcore.
No, the entry point of the patient's age is 35 to 75. So if it's a 35-year-old woman, please be part of that study.
Right, ma'am. So, ma'am, I'll message you for the necessary documents.
Yes,
Thank you so much. Thank you, ma'am.
Thank you.
Thank you, ma'am.
Bye, Megraj.
Thank you for the
Nice
wonderful.
connecting
Yes.
Thank you,
Bye,
Dr.
ma'am.
Monica. Good night, everyone.
Thank you. Most
Thank you.
welcome. Really enjoyed. Bye.
Bye-bye.
Bye.
Sorry.
Support team